Firozabad, Gulbarga, Guwahati, Gurgaon, Haldwani, Harmangarh Obs and Gynae Society. A very, very warm welcome to each and everybody over here. Before I start the program, I'd like to introduce you all with one of the very, very intriguing personality, convener of this program, Dr. Jaishree Sangeeta. Ma'am is consultant Ma'am is consultant obstetricians and laparoscopic surgeon, Sehadri Hospital, Palapur and Malikam. She is founder secretary, Bhimavaram Obstetrics and Gynecology Society, secretary IMA Palapur. She has many awards, one of which is Shan S. Ratnam Young Gynecologist Award, Coxie Dhira Award, and her area of interest are laparoscopy and infertility. She's a very eminent personality, a very, very warm welcome, ma'am, and over to you.
Thank you so much, Mr. Kumar. That was a very enthusiastic introduction. Thank you for those kind words. So I will take the program forward. I would like to introduce Dr. Asha Jain. Next slide, please. Yeah. So ma'am currently is the director of SMSA Hospital, Raipur. She is the medical director of CPRS, elected member of CG Medical Council, zonal chair, Foxy Food Drug and MSc Committee, West Zone. She is also the chairman of Mission Pink Health IMA Raipur, executive member of various organizations. Previously, she's been the president of Raipur Obstetric and Gynecological Society, vice president of IMA, and she's also been the president of Rotary Club of Raipur North. Her fields of interest are saving the uterus, fetal medicine, critical care, preventive oncology, and colposcopy. I now request Madam to please say a few words.
Thank you. Before the formal welcome address, I would like to take the blessings of the divine. Please continue with slide sharing. Namaskar, everyone. We will first pray to the divine before we start the program properly.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा।
Namaskar. I welcome our guest, our chief guest, Dr. Suchitra Pandit Madam, our guests of honor, Dr. Bipin Pandit and Dr. TLN Praveen. I also welcome our speaker, Dr. Vivek Krishnan, the chairpersons, Dr. Surekha, Dr. Poonam Agrawal, and Dr. Jaishree Tewari. I welcome the second speaker, Dr. Prathima Radhakrishnan ma'am, and the chairpersons, Dr. Saroj Kumar, Dr. Panchanan Das, and Dr. Rajshree Paladi. I would also like to welcome our experts, Dr. Vandana Bansal and Dr. Vatsla Dadhwal, who have agreed to chair this session. I welcome our panelists, Dr. Revathy Sadasivam, Dr. Garima Sharma, Dr. Ira Vishwas, Dr. Neeru Thakral, Dr. Anushree Raval, Dr. Renu Setia, Dr. Prerna Rathor, and Dr. Dharani N. Also, Dr. Gokul Priya, who had to join at the last moment because there was an inspection with Dr. Revathy, and the secretary of Guwahati Society had a death in the family, so she was unable to join. I welcome everyone. Bipin sir is also here. Welcome everyone to this webinar. The searchlight today is shining on updates on monochorionic twins And we have the bestest speakers that you could have on this topic. You have Dr. Vivek Krishnan, who is going to make things crystal clear where problems start in monochorionic twins. You have Dr. Radhakrishnan ma'am, and we have Praveen sir, who's going to actually, help us through the actual understanding of the subject. So I welcome all of you. I also welcome all the delegates who have joined in. I request for the CV of Suchitra ma'am. I would like to introduce Dr. Suchitra Pandit ma'am, who doesn't need an introduction. She's so known to Foxy for the last 25 years. There's hardly anyone who doesn't know her. But it's a pleasure to just read out that CV. She is the past president of Foxy, Foxy representative to SAFOG, associate member of FIGO Ethics Committee, chairperson AICC RCOG in the past, president ISOPAB also, president Gestosis India, president Foxy and ICOG. She was also the president of Mumbai Society, professor and unit head LTMMC and LTMG Hospital Sion till 2009, PG teacher for 39 years. She's conducted a number of programs, initiated a lot of activities. She is the winner of Lord of Planets Award, FIGO Women's Award, Maharashtra Medical Council Award, Honorary Fellowship of Nepal Society, MOGS, Dr. Desai Award for Excellence, Dr. Patki Award for Think Global. She has 124 publications, has authored many books. So welcome, ma'am, to this webinar. We would really love to hear a few words from you.
Thank you very much, first of all, Asha, because it's great to be on the Searchlight, like the name very much, because Searchlight gives you, it's a very catchy name, which tells you, okay, fine, you're looking out for something important, and there you have. Today's topic is, monochorionic twins, which is so important. And, when you're choosing your subjects, you have to, you're actually appealing to the audience, and you've got a good array of speakers and experts to take us through that entire particular webinar. And what is very, very good is that all the societies, I think almost 8 of them, Bhimavaram, Erode, Firozabad, Gurgaon, Guwahati, and Haldwani, Hanumangarh, and of course Gulbarga, and all of these have got together, and they're coming. So what I really like about all our programs is when you're trying to reach out to each and every society. That is important. That's the way the Searchlight can throw light on many, many issues. And all the best for your future journey, Asha. Wishing you all the best. And, let's hope that this program also is going to be one more important program of your Searchlight series. Thanks to everybody who's here today. Some of them are known faces, some of them are unknown, but I know all of them because we have been to most of these societies except Hanumangarh. But I hope sometime in the future I'm able to travel there. Once again, Asha, all the best, and thank you very much for having me.
Thank you, ma'am. Thank you for being here with us today. Vipin Pandit sir was on an assignment, so he had a problem in his friend. So we'll introduce him fast, and he can then be free.
Hello, I'm here. I'm here, very much here.
Yes, sir.
Sorry.
Welcome, sir.
Yeah.
So Vipin Pandit sir is the past executive council member of Maharashtra Medical Council. He was VP Foxy 21 to 22, past president MOGS 2018 to 19, past joint secretary Foxy, treasurer AICOG Mumbai, past president and trustee Association of Medical Consultants.
Asha,
And he sings very well. He sings very, very well. So welcome, sir.
Thank you very much for giving me opportunity to be with this. And thank you all the 8 societies and their office bearers for coming together for this very important and interesting topic. It's like a group practice, right? I am in a group practice for the last 43 years with other gynecologists. So a group practice is a little rare, but a combined effect of all these societies coming together to discuss very interesting and very important topic is required today. So everybody's knowledge is brought together and pulled together, and we give a lot of experiences we share together. Your topics you have suggested are very good. The incidence of twins is increasing because of various reasons, including ART and IVF and induction of ovulation. At the same time, the complications of monochorionic twins are very well known, and placenta itself is a very mysterious organ. We scientists and we doctors still have not understood about placenta. The root cause of many problems, including preeclampsia, IUGR, changes due to diabetes and so many other things, infarcts, and of course, in twins, again, it creates a lot of complication. Sorry, I'm traveling, I'm in the car, but it was my honor to be with you all, to share with you. My friend's father has expired, so I will have to leave. And after some time, I will listen to all you all and then leave in a short. Thank you very much.
Thank you so much, sir. Thank you. Now, I would like to welcome Praveen sir, TLN Praveen sir. When I started learning fetal medicine, his video on second trimester scan, which is available on YouTube, is what I watched over and over again. And then I met him in many conferences. He has been very kind to join us today. He's a radiologist, but he's with us. He's practicing fetal medicine and gynec imaging for 35 years. He's passionate in evaluating fetal well-being and invasive, teaches and trains postdoctoral students. His hobbies are running, hiking, and watching movies. Beautiful. He has a certificate of excellence for first coronary angioplasty in the country. He has an appreciation award from Foxy, Dr. Ashok Mukherjee Gold Medal, Indira Priyadarshini Award 2014, Lifetime Achievement Award 2018. He's the past Vice President, National IRIA, past President, IFUMB, and past President, Society of Fetal Medicine. He's published 2 chapters in Textbook of Radiology, has published peer-reviewed articles, delivered lectures, reviewer for American Journal of Sonography, Journal of Radiology, Journal of Fetal Medicine, and member of the editorial board of IJRI. He has been kind enough to be here. He's extremely humble and down to earth. Welcome, sir, to this webinar.
Asha, thank you very much for involving me in this program. And as the title itself says, it's a searchlight. I think it's a beautiful, catchy word, and I think it will attract a lot of. And then its most important thing is that the initiation that you took and the topic which you choose are really, really interesting. We all know in our day-to-day practice, twins is double trouble. Not only that, when we have a monochorionic, diamniotic, when there is a single placenta, first and foremost thing in the first trimester itself, we need to decide whether it is a fused placenta or a shared placenta. And whenever we have problem with shared placenta, all the trouble starts off because this sharing may not be equal. And most of the unique abnormalities which are very common with this monochorionic twins are basically because of unequal sharing of the placenta. So I think we have wonderful speakers, particularly Vivek Krishnan, my friend, who is very knowledgeable and particularly working on medicine and twins. And Prathima Radhakrishnan has been doing some invasive procedures in managing these patients. Thank you once again, and I think it's going to be a very useful program, and we will learn a lot from it. Thank you once again.
Thank you so much, sir. Thank you for being with us.
Okay. What is his name?
End our inaugural ceremony, and I request Dr. Jaishree to please introduce the chairpersons.
I would like to introduce the chairpersons of the first session. We have with us Dr. M. Surekha. Welcome, ma'am, to today's session. Madam is currently a consultant at Surya Kamaleni Hospital at Kaikluru. Her areas of interest are high-risk obstetrics and minimally invasive surgery. She belongs to Bhimavaram Obstetrics and Gynecological Society. Next, we have Dr. Poonam Agrawal. Madam is the president of Firozabad Obstetrics and Gynecological Society. She's been the secretary of the same previously. She's attended various conferences as a speaker She's also been a panelist in various CMEs. She has published in various journals, especially in the subject of STDs. Her special interest is fibroid uterus adolescent health. She's done a lot of social work. So Madam has also been the organization secretary for a CME on basic laparoscopic surgery. I would like to welcome you to today's session, ma'am. We have Dr. Jaishree Tewari with us. Madam is the founder and managing director of Tewari Maternity Center and Nursing Home at Haldwani. She has almost 28 years of experience in obstetrics and gynecology. She's been the president at Haldwani Obstetrics and Gynecological Society. She has also formerly been the vice president of the IMA at the same. She has special interest in high-risk obstetrics and infertility. She has organized various medical camps for women's health in Haldwani and nearby areas. Welcome to today's session, ma'am. I request one of you to please introduce the speaker for today's talk.
Requesting everyone who's not speaking, please mute yourselves. There's a lot of echo. If you're not speaking, please mute yourself.
I request Dr. Surekha to please introduce the speaker. Ma'am, would you like to do the honor?
Jaishree, ma'am, you need to log out from one device. Please log out from one device.
Yeah, so there seems to be a little confusion there, yeah.
Good evening, everybody. I'm very happy to be part of this Searchlite program today and the most important topic of Monochorionic Twins. I'm very much delighted to introduce Dr. Vivek Krishnan, sir. He's presently at the Amrita Hospital, Kochi. He's the associate professor and head in fetal medicine perinatology, Amrita Institute, and adjunct faculty at KMC Manipal. And he's been the part of faculty of the fetal ultrasound program. And faculty, one learning master classes in fetal neurology, and board member of specialist board, MFM National Board, and a member of SFM. And Sojourn, he's the Sojourn coordinator of Fetal Medicine Foundation India. He specialized training in certified training in fetal therapy at Berlin, and he certified training in fetal neurology. He has so many publications. Few of them are like obstetrics 12 long cases specific for postgraduates and 27 peer-reviewed papers in index journals. I'm happy to introduce him to this session, and please show light on the monochorionic twins and the importance of placenta in that management of monochorionic twins. Sir. I'm handing over to sir to speak on the present topic.
Thank you so much, ma'am. And respected chairpersons, respected dignitaries, Vipin sir, TLN sir, Asha ma'am, Sujitra ma'am, Dr. Jaishree, and the other dignitaries. First of all, thanks to Asha ma'am for this wonderful opportunity. I didn't know this was such a big program. 7 societies coming together, so something great to see. First of all, I'll start with a disclaimer because there is some national highway work going on even as I speak that I can see right in front of my eyes. And therefore, they've dug out all the Wi-Fi cables, so I'm just connected to the phone Wi-Fi. I hope the slides come through. If there's any issue, please let me know so that I can stop and then go back to the slide if required. I'll try sharing my screen and hope this works. We did try this out before the lecture started. Are you seeing my screen right now, ma'am?
Yes, it's visible, sir.
Yeah, full screen?
No, not yet. You have to make it. Yeah, now it's visible, sir. Full screen.
Okay, I'll keep my video off so that I save on bandwidth as well. Yeah. Right, so I've been asked to speak on the placenta in monochorionic twins, and I'll start off with asking you a small general knowledge question as to how many of you recognize this gentleman. I'm sure at least some of you in the audience would know him.
I know him, sir.
Sorry?
Kipros.
Yeah, but several conferences I've asked this question and I've got answers like Saddam Hussein first.
Kipros Nicolaides.
Yeah, it looks a lot like Saddam Hussein, but that's besides the point. Now, even if you know this gentleman or don't know this gentleman, I'm sure Some of you at least would have heard one of his most famous statements that he's ever made till date. And that famous statement is that there is no twins that you can speak about. There should be no twins, but only monochorionic or dichorionic twins, which means you cannot ever call twins without addressing the issue of chorionicity. Now, such has been the impact of the statement over the years, and people like me and Praveen sir and Asha ma'am and Prathima ma'am who practice fetal medicine, that today if I see a set of twins when I'm doing a scan at the 12 weeks or 13 weeks of pregnancy, even if I forget to say congratulations, I will never forget to say chorionicity. So that's the kind of impact that statement has had. And he said that not without reason, because chorionicity is indeed such a big deal when you talk about anything and everything related to twins. Now, why is chorionicity such a big deal? Because everything about twins differs based on this one entity called chorionicity. Be it the zygosity assessment, your screening protocols are bound to be different. The complications that you would expect between dichorionics and monochorionics are different. The frequency of follow-up visits that you would ask them to come back for are different in between the two. And also, because all of these are different, your management decisions are also going to differ with a capital D when you talk about monochorionics versus dichorionics. Now, why is there the difference based on chorionicity? Now, if you look at dichorionic twins, the only thing that's being shared here is probably the uterus of the mother and the mother herself. But within the uterus, nothing else is shared. You have two completely different separate placentae. You have two separate sacs. You have two separate cords. And sometimes, like Praveen sir said, you might even find a fused placentae. But even in the fused placentae, there is no sharing involved, as I will come to in a couple of slides from now. Unlike this, quite in contrast, when you talk about monochorionic twins, there is a lot more of sharing that is involved. Of course, they share a placenta. They have both the twins have just one placenta and they share it. And because the placenta are shared, the circulations are shared within the placenta. And some of them share a common sac, which you call as monoamniotic monochorionic twins, or more twins as we call it. Some share a fetal organ. For example, in acardiac twin or trap sequence, there's only one heart that pumps for both babies. And some go to the extent of sharing parts of their bodies as well, like we see with monochorionic conjoined twins. So unlike dichorionic twins, where, like I said, perhaps the only thing is being shared is the mother and her uterus, when it comes to monochorionic twins, because of this placental sharing, there's a lot of sharing that's involved, and that leads to complications unique to monochorionic twins. Now, what are these complications? You can sum up these complications as two key issues. So when two babies share one placenta, you have two key issues there. First, of course, is the issue with abnormal communications within the depths of the placenta, which we call as abnormal vascular anastomosis. The second problem is, like Praveen sir said again, the placental sharing may not be 50-50, it may not be equal. And we know from past experience, from real life situations, that if the ancestral property is not divided or distributed equally amongst children, there's always a problem that comes up. Similar situation when you talk about sharing or unequal sharing of the placenta in monochorionic twins. The best way to study this perhaps would be to do a placental dye injection, wherein after delivery, I mean, of course, you cannot make out these distinctions always by ultrasound because you cannot see the vascular connections by ultrasound. You might possibly document cord insertions, and that might give you a clue to the extent of placental sharing or the inequality of placental sharing. But the best and gold standard method to really study the placenta is to postnatally do a placental dye injection study. Now, this is one case where we did a placental dye injection study. This was in the times of the Qatar FIFA World Cup. That's why the colors are such. Argentina on the right and Portugal on the left, two of my most favorite teams. And I'm sure it's a favorite team for a lot of you as well. That's why the colors are like these. But basically what you do is you cannulate the artery and the vein on both sides. So this is one cord, that's the other cord. So you cannulate the artery and the veins and you inject colors, poster colors or fabric colors of different shades. So that one colors the artery in green or red and the other takes the other color. Similarly on the other side as well. Now looking at this placenta, how do you identify which is an artery, which is a vein, which is the anastomosis, and so on and so forth, is basically by looking at which vessel crosses over the other. Now remember that arteries always cross over the veins. So if you take this green and blue areas here or vessels here, the artery will be the one that crosses over the vein. So you would assume that the red is the artery here. On the other side, you can very clearly see that the white is crossing over the blue. So white is the artery and blue would be the vein. That's how you identify by looking at these colors here. Now, if I'm the person who has done the cannulation, I would know, of course, which is the artery and the vein, because the artery is smaller in caliber. You have two of them, and the vein is larger in caliber. But from a placental image or dye-injected image, you can make out artery and vein by looking at the vessel that crosses over the other. You can also identify donor and fetal or recipient vessels by looking at the direction in which they branch. For example, if I look at this vessel, I know it's branching away from this cord. So this is a vessel that belongs to this fetus. Whereas if I look at this particular vessel, it is branching away from this cord. So this vessel belongs to this fetus. Now, when you get to see the whole placenta, this is not difficult. But when you're doing a fetoscopy, you only see this area of the placenta. So to identify which vessel comes from where, you look at the direction of branchings, and that tells you whether it comes from this cord or from this cord. So these are basic principles that we need to understand while we look at dye-injected placentae. So let's talk of those two key issues that we spoke about. First, of course, is the issue with abnormal vascular communications. Now, to understand placental anastomosis better, let's zoom in on a placenta. And the moment you zoom in into any placenta, you'll realize that if it is a monochorionic placenta, it is ubiquitous that there will be arteriovenous or arterioarterial or venous-venous anastomosis. Some form of vascular anastomosis is the rule if you're looking at a monochorionic placenta. But you have three kinds of anastomosis. One is when an artery connects to a vein. Second is when an artery connects to an artery. And the third is when you connect a vein, when a vein connects to a vein. Now, if you notice, I've not mentioned a vein to artery connection here, because if an artery connects to a vein or a vein connects to an artery, the blood flow is always going to be from artery to vein. So that would be an artery to venous connection in the opposite direction. So you'll understand that better when I come to the placenta as well. Now, we need to understand that anywhere in the body, forget the placenta, anywhere in the body where an artery connects to a vein, blood can only flow from the artery to the vein. Now, this is because arteries have muscle
Vivek,
power.
your voice is
They
shaking.
have blood
Your voice
in
is shaking.
direction, and that direction is from the artery. Okay. I'm getting a message that the internet connection is unstable. Is it better now?
Better now. It's better now.
Yeah, I've just got a call in between this. Yeah, so what I was saying is anywhere in the body when the artery connects to the vein, there's only one direction that the blood can take, and that is from the artery to the vein. As I said, that's because arteries have muscle power and can propel blood in the direction it wishes to. Whereas veins are capacitance vessels, they can only receive the blood that is pumped into them from the arteries on the other side. So this is like a one-way traffic. Blood goes only from the artery to the vein. And that's what happens with an arteriovenous anastomosis, or an AV anastomosis, as we call it. Now, on the other hand, if an artery connects to an artery, both the arteries have muscle power. So the net direction in which blood flows will be decided by the artery which has got a stronger muscle power. Or in other words, it will be decided by the blood pressure that is higher on one side and lower on the other side. So that difference in blood volume or blood pressure is going to dictate the direction or the net direction in which blood flows from one artery to the other. So this is like a bidirectional flow, or you have a two-way traffic there. Blood can flow from left to right if there's more pressure on the left. It can flow from right to left if it's the opposite, and so on and so forth. So what this does is basically it is a balancing kind of anastomosis. Whereas AV anastomosis or unidirectional anastomosis can only pump blood from the artery to the vein. So if you have too many AV connections from left to right, the blood becomes more on the right side. And if you have artery to artery connections, they will try and even this out or balance this out by reducing or pushing blood back from the right to the left. So these always play a kind of balancing role when you talk about intraplacental anastomosis. You could also have a vein connecting to a vein. Now remember, veins cannot push blood in either direction, but they can only transmit the vessels or the blood that comes from the arterial vessels and then push it in the same direction forward by virtue of inertia. But having said that, Vein-to-vein connections are still not properly understood in the settings of complications related to monochorionic twins, but there is enough data from a large study that says in twins that develop TTTS, they have somehow found an increased number of vein-to-vein anastomosis. And the logic that is given for this is because veins do not have muscle power, they are easily susceptible to compressive effects. For example, if the baby's position is such that the baby is lying on the placenta, that pressure is significant enough to cause a compression of the veins. So if this vein gets compressed, that effectively pushes blood in the opposite direction. And then this starts to function like a functional AV anastomosis, pushing blood in one direction rather than transmitting blood that comes from the veins. So obviously, when you have a large number of VV anastomosis, there is the propensity to develop TTTS in such cases. If for some reason there is polyhydramnios, or for some reason the twin lies and compresses the placenta and so on and so forth, these can then start to function like a functional AV anastomosis. So which is why they reasoned out that the number of, or the increased number of VV anastomosis that they found in twins that developed TTTS, this was probably what was happening in situ. Now, as I said earlier, it is a given that if you're dealing with a monochorionic placenta, there is bound to be anastomosis. The number of anastomosis can vary, the type of anastomosis can vary, the size can vary, but it is unequivocally present in every single monochorionic placenta. Now, as I said, because of these connections, this is like, imagine roots branching out once they enter the soil. So the cords coming in with the vessels, they just branch out once they enter the placenta. And somewhere along the line, these branches meet and that forms an anastomosis. And because of these connections, all identical twins or all monochorionic twins transfuse blood back and forth from one twin to the other and from the other twin to this one. So this keeps happening in every single monochorionic placenta. However, in 85% of monochorionic placentae, this transfusion is kind of balanced, which means if, let's say, 50 ml of blood goes from twin A to twin B, the same 50 ml or at least 45 to 55 ml could come back from twin B to A. And this results in an equal transfusion. And if that happens, there are no complications that happen. But in the other 15%, there could be an unequal transfusion that happens because of abnormal connections or unbalanced connections within the placenta. And that is what leads to a net transfusion or an unequal transfusion. And that is what leads to complications in monochorionic twins. Let me just give you a simple example. Here you have two twins, a monochorionic twin pair as depicted by a single common placenta. There are 3 arteriovenous connections from twin B to A. Remember, arteriovenous connections are unidirectional, so blood will flow through these anastomosis only from B to A. But there are only 2 AV anastomosis from twin A to twin B. And if we assume that all of these are of equal caliber, which in most cases they are, then over a period of time, there is going to be a net transfusion from twin B to twin A. And therefore, you would expect that there will be TTTS that develops in this set of twins. And twin B will become the donor, and twin A becomes the recipient over a period of time. So as much of blood that comes from B to A does not go back from A to B. But then all of these kinds of connections, abnormal connections, do not develop TTTS because, as I said earlier, you would have arterial anastomosis that play a protective role. So even if there is a 3:2 ratio of AV connections, if there are enough number of AA connections to balance out this imbalance or unbalanced flow or net flow from B to A, these babies will not develop TTTS. So that's how important the role of arterial anastomosis is in preventing complications related to unbalanced transfusions from one fetus to the other. Despite that, if there are not enough arterial connections and you have an unbalanced AV discordance, then that 15% is the set of cases where you will have an unequal transfusion. And that leads to 2 conditions called twin-to-twin transfusion syndrome or twin anemia polycythemia sequence. Now, the difference between TTTS and TAPS has got to do with the size of the vessels that are involved. In both of these cases, The culprits are abnormal AV or unbalanced AV connections. But in TTTS, the unbalanced connections are large AV connections, whereas in TAPS, these connections are still AV, but very, very tiny hairline vessels somewhere in the periphery. Now, the difference being, if you have large vessels being connected and unbalanced, the net transfusion that happens from one fetus to the other, or from the donor to the recipient, the volume of transfusion is going to be significantly high. So when there's a sudden increase in volume on one side and sudden reduction in volume on the other side, that triggers endocrine pathways like renin-angiotensin, as well as atrial natriuretic peptide pathways in the donor and the recipient respectively. Now, this endocrine triggers leads to increased urine output in the baby that receives more blood by the atrial natriuretic peptide action. Therefore, that fetus develops polyhydramnios. The other baby tries to conserve blood by stimulating renin-angiotensin aldosterone mechanism, so it retains its blood volume. So urine output comes down, and therefore that twin goes in for oligo. So you get oligopolysequence when you have large AV imbalances that are there, and that is what leads to TTTS. On the other hand, in TAPS, it's again AV anastomosis or unbalanced AV anastomosis that are the culprits, but these are tiny vessels, and therefore the babies get time to adapt to this net transfusion, unlike in TTTS, because of the volume of transfusion being significantly low. So because the net transfusion is not high volume, there is no triggering of the endocrine pathways, and therefore these babies do not develop the oligopolysequence, unlike in TTTS. But what they do develop is, because of the slow bleed, one baby becomes anemic and the other becomes polycythemic over a period of time. So that's what we call as twin anemia polycythemia sequence, or TAPS sequence. Let's look at some placentae to understand this better. Now, on the left, you see a placenta. You see one cord is inserted here, the other cord is inserted here. So the territorial sharing does not look too bad. But if you look closely, you see something right in the middle there that you don't see in this placenta on the right, on the other side. Now, this is a intertwin membrane. It's a very thick intertwin membrane, suggesting to you that this is not a monochorionic placenta, even though it looks as one single placenta. This is actually a fused dichorionic placenta. Now, even in a fused dichorionic placenta, because of this thin intertwin membrane there, what you would notice is, even though these vessels come close to the membrane, none of them are crossing over to the other side. So even in fused dichorionic placenta, you will not find vascular anastomosis between the vascular territories. So they function as two separate placentae, even though they appear fused when you look at it macroscopically. Microscopically, there are no vascular connections between the two. On the other hand, if you look at this particular placenta, there is no thick intertwin membrane. One cord is inserted into the center, the other cord is inserted into the periphery. And if you look closely, you would find plenty of connections between the two. There's one here, there's one here, there's one here. There's so many connections between the two cords and the two vessels. So this is a monochorionic placenta. As I said, it is ubiquitous that you will find anastomosis in placenta. It can range from 1 anastomosis to 20 anastomosis, but there will certainly be at least 1 anastomosis in all monochorionic placentae. Now let's look at this particular placenta here. Here you see this is one cord insertion, that's the other cord insertion. This is right at the margin. And you see this is the artery, because blue is crossing over the red everywhere. So this is, the blue is the artery here. The red is a vein as far as this cord is concerned. On the other side, the green is the artery because that's crossing over the yellow. So green is artery, blue is artery. So this is vein. So here you have an AV anastomosis from this. So this artery is fusing with this vein. So that's one AV anastomosis. Now here you have another anastomosis that looks like this is vein and this is artery. So this is an AV from the other side. Here again you have an anastomosis. Here there is an AV anastomosis. Here there is an AV anastomosis. So we find plenty of AV anastomosis, which looks unbalanced because you have 4:1 there. And this is a case that developed TTTS because of this unbalanced AV. And if you look closely, you're not finding any artery-to-artery anastomosis. So this is a 4:1 AV connection. And therefore, as you would expect, there is going to be a net transfusion from this side to the other. So this twin becomes a donor, that becomes a recipient, and therefore you get TTTS in this case. Here is another example. Here I've labeled all the connections for you to make it simpler. That is one AV, this is another AV, this is another AV. So there are 4 AVs from one side to the other, and only 2 from this side. So therefore, there again, there is a net transition. I've already marked donor and recipient here for you. So this becomes a donor, the other becomes a recipient, because there is a net transfusion from this side to that side. So 4:2. And again, if you look closely, I do not see any artery-to-artery anastomosis. So there is no protective effect there. So this was again a case that would develop TTTS. Now, how about this one? If I start looking from one end of the potential vascular equator here to the other end, I don't see any connections here, but I see one large AV anastomosis there. Now, one large AV anastomosis, which looks completely unbalanced because there's nothing else going from the other side to this one. So this AV anastomosis would result in a net transfusion of blood from this through there to this side. So you would expect this babies to develop TTTS. However, they did not, because when you look very, very closely, there is a small fellow hidden underneath here, beyond what you could see here. So you have to turn this around to see, you can see that coming from here. So there is a large AA anastomosis that is there in the periphery. This is AA because you can see the color is same on both sides. All this blood has gone from this side to this side when you injected the dyes. But in reality, because this was a net transfusion from this to this side, this would have taken blood back from this and balanced it out. And this is why this was the placenta, that baby that was delivered at 36 weeks and did not develop TTTS, which came as a surprise when you see this connection, but it is no surprise when you see that there is an AA anastomosis right at the periphery there. So this is what saved this set of twins from TTTS. So that goes to tell you how important AA anastomoses are in playing the protective balancing out role. And the reason some of these stage 1 TTTS do not progress, 50% or half of stage 1 TTTS do not progress for the same reason. They would have enough number of placental artery-to-artery anastomosis that would otherwise balance the net transfusion that would have otherwise occurred from one twin to the other. Now let's look at this placenta here. These tiny hairline vessels, there is one connection here. So this is an artery because this is crossing over here. You can see that that's an artery. This red is also an artery because it's crossing. No, this blue is an artery because it's crossing over the red there. The blue is crossing over. So that's the artery there. There's a small twig-like connection that is formed there. There's another twig-like connection between this artery and this artery here. There's another small twig here. So these are all not big AV anastomosis, but sorry, this is A to V. So this is a vein here. This is an artery. So that's an AV. Again, another AV, small AV vessels, hairline AV anastomosis. So this baby would not develop TTTS, but like we said, because there's no high volume transfusion, but a slow leak happening, this placenta is destined to develop TAPS, which is exactly what happened in the set of twins. So this case of small hairline AV unbalanced anastomosis, you could see can cause twin anemia polycythemia sequence. Here is another case. There are no big connections here, but if you look very, very closely, let me zoom this up for you. This blue is an artery because it's crossing over. There's a red that goes underneath this, and this artery is connecting with this vein here. So this is again very superficial artery to vein connection, and that is what leads to twin anemia polycythemia sequence, where you don't have the typical volume or Leica discordance, but you have only discordance in hemoglobin, and it sets in much slower than TTTS would develop. So those were the problems that we saw with abnormal AV connections. Now we come to a different scenario altogether, which we call as a trap sequence, where the culprit vessel is not an abnormal AV connection, but rather an abnormal AA connection. And remember, all this while we were harping on the fact that AA connections are protective, but here is an exception. When you have a large AA connection very early in pregnancy, like you see with cases that develop trap sequence, these placenta have a very peculiar angioarchitecture. Now, what happens is usually the cords are inserted very, very close to each other. In 70 to 80%, there's only a single umbilical artery on one side and a 3-vessel cord on the other side. And there would be a large artery-to-artery anastomosis, which often is accompanied by a large vein-to-vein anastomosis as well. Now, what happens is sometimes very early in pregnancy, if there is a pressure differential for some reason between these two twins, let's say that this twin had some cardiac abnormality and there was bradycardia. And when there's bradycardia, we know that the heart rate falls, the cardiac output falls, so the blood pressure falls. So this baby had a low blood pressure, this baby had normal blood pressure. So there is a pressure differential that was created. You have a large artery-to-artery anastomosis. So when there is a pressure difference that is created and the large connection between the two, this baby tends to suck out blood from this baby through this artery-to-artery connection. And it is like if you've seen people sucking out petrol from petrol tanks using a pipe, using a tube. Once you start sucking out and the petrol starts flowing, you don't need to keep sucking out again. It keeps flowing by inertia. So once something very similar happens here, because of the pressure differential, there is a net transfer that happens from this side to the other side through the anastomosis. And once that sets in, it keeps flowing on forever. So then what happens is this baby, instead of getting pure blood from the placenta through the umbilical artery, ends up being fed by impure blood that is coming from this twin through the artery-to-artery anastomosis, going up through its umbilical artery. And we know that oxygen is vital for normal morphological development. So when this impure blood is what is feeding the baby, it is quite natural that the baby does not develop morphogenetically normal. It becomes abnormal. It takes very abnormal shapes. And so this twin gets called as a bump twin. This twin gets called as the perfused twin or the acardiac twin, because this oxygen that it gets, impure blood that comes from this, is not enough to help the baby develop its upper story as well as the heart, or a normal excretory system for that matter. So this becomes a very amorphous looking mass. And that's the artery. You can see how close these two arteries are, two cords are inserted. There's a large artery-to-artery connection in the depth there and a large vein-to-vein connection here. This is a typical substrate for development of a trap sequence. And as I said, because the oxygen is not enough for normal morphological development, the abnormal twin or the perfused twin or the acardiac twin can take all sorts of amorphous shapes depending on how much oxygen it is able to extract from the other twin. There are different names that comes along with it, very fancy. You don't have to remember any of these names anymore, because one common name is good enough for all of these, and that is what we call as the trap sequence, because what is common to all of these will be the reversal of blood flow in the umbilical artery of the abnormal twin, which can very well be identified by Doppler examination. I'm sure Prathima ma'am will be showing you cases of this as well. So far what we were talking about is the problem with abnormal vascular connections or communications. We spoke about another key issue when two twins share a common placenta, and that is the problem with unequal placental sharing. Now remember, unequal placental sharing is what leads to what we call as selective fetal growth restriction. It is quite intuitive that you would believe that if one twin gets a smaller share of the placenta, it is bound to grow smaller than the other one, and therefore that baby becomes selectively growth restricted, which is what we call, and the other baby would continue to grow normally, which is what we call a selective fetal growth restriction. So this is a placentagram from a set of monochorionic twins that develop TTTs, that develop selective growth restriction. You can see very clearly that this cord that's inserting here has taken a lion's share of this placenta, whereas the other cord that inserted right at the periphery got a much smaller share, much fewer vasculature, and therefore it is quite natural that this baby would end up being smaller than the other one. So basically, selective fetal growth restriction is a story of how two babies share a common placenta. They fight for resources, they fight for territory, and one baby becomes smaller than the other because this territorial sharing is what determines or affects how these babies grow, their weights, their sizes, etc., etc. Now, what we need to understand is how a placenta gets shared in a monochorionic twin set is dictated by where the cords are inserted. So if you have a central insertion, which means both the cords are inserted into the central area of the placenta, the sharing is pretty much equal, and therefore these go along much happier than otherwise, and would would probably come to a normal outcome at term. Say, for example, this here. You can see this cord is inserted here, this cord is inserted here. Both are slightly off-center, what you would call as eccentric cord insertions, but you can see that the territorial sharing is almost 50-50. So if both are inserted to the same point, pretty much the sharing is going to be equal. If both are in the center, it's the same. If both are in the periphery, it's the same. But as long as the placental territorial sharing is the same, these twins would not develop selective fetal growth restriction. You also have the anastomosis that are marked there to understand the concept of anastomosis. On the other hand, if you have one cord that's inserting into the margin of the placenta and the other that's inserting into the center of the placenta, you have what we call as the marginal central discordance of cord insertions, and this can lead to unequal sharing of the placenta. This baby gets a smaller share, this gets a larger share, and therefore that can lead to problems, as you can see here. This is inserted right at the center, so this takes almost 75% of the placenta, whereas this cord is inserted only at the periphery, the margin of this placenta, and therefore it naturally gets a smaller share and less vasculature. This could be the same placentagram that I showed you, where the distribution was completely unequal in the beginning. Now here is the ultrasound example of the same thing. You can see the two cord insertions here. One cord, a tiny cord, is inserting right at the periphery, the margin. The other cord is inserting to the center. Therefore, this cord would take a major share of the placenta. The other one would get, obviously, a minor share. And this is very much a substrate for developing selective growth restriction. Here is another example. You can see peripheral and central, or marginal and central, and you can see how the territorial discordance is very clearly brought out in this dye injection study as well. Now, worse still, if you have a velamentous cord insertion. Now, in velamentous cord insertion, the cord is inserted not even into the margin, it's inserted outside the placenta into a membrane, and from the membranes, the vessels come and seek blood supply from the placenta. It's like you don't have a rightful access to the placental territory. Imagine you have a department store right next to your house, but there's a large wall that is built between your house and the department store. You do not have rightful access to the store next door. You have to take a long walk around and then come to the next door. So it's like a pretty similar example that you can think of. So the sharing is going to be extremely discordant in these cases. As you can see in this particular picture, this is a velamentous cord insertion. You can see that the cord is inserting into the membrane there, runs for a fair distance through the membrane, and then finally enters the placenta at this point. So this is how you would see a velamentous cord insertion. And this is a placentogram or a dye-injected placenta showing you the same thing. The cord attachment is not even into the periphery. It's inserting here into the membranes. You can see vessels running through the membranes, and then it is reaching up to the placenta. So the placental share or territory for this baby is extremely small compared to the other twin, which is taking up almost 80 to 90% of this placenta because its cord is inserted into the center. Therefore, the vascularization is much more. You have a lot more branches and a lot more territorial gain for this baby compared to this particular twin. These are the placenta that are notorious to develop vasa previa, especially you have to be on the watch out for these, and by doing a transvaginal sonogram to make sure that there are no vessels overlying the cervix there. So as I said, velamentous cord insertion, as you would expect, there's a very, very strong association. In fact, the strongest association of all these three types that I showed you of central, marginal, and central velamentous, the highest association with selective fetal growth restriction is when you have a velamentous cord insertion. Now, that story does not end there. Now, the management of SFGR, I'm sure Prathima ma'am would cover this, but one particular challenge that I would want to draw your attention to is the fact that placental discordance, of course, depends on the cord insertion sites, but very often the placental discordance does not match the weight discordance, or your weight discordance would not be in similar lines as you would expect based on the placental discordance. For example, if the placental sharing is, let's say, 1/3 and 2/3, if the 2/3 baby weighs 2 kilograms, you would expect the 1/3 baby to weigh 1 kilogram. But in real life, what you see is the 2/3 baby would be weighing 1.7 and the 1/3 baby would be weighing 1.3. Now, this again happens because of the protective role that artery-to-artery anastomosis play. And the number and extent of arterial-to-arterial anastomosis that do the process of rescue transfusion, as we call it, will balance out this to a large extent, balance out the territorial or the placental sharing discordance to a large extent, so as to minimize the effect of this territorial discordance and to minimize the possibility of SFGR in these twins, which is why the placental discordance will not always agree with the weight discordance. And because you cannot see the number of AA anastomoses that are going to be there, you can never predict the natural outcome or natural history or outcomes of these twins. So that's why managing SFGR cases becomes really challenging. That's where the role of the Grata-Costas classification comes in, because you can only manage them based on their ultrasound behavior, their clinical behavior, and not based on placental discordance or cord insertion discordance. Because as I said, the natural history depends not just on the placental discordance or the territorial discordance, but also on the number and type and size of the protective AA anastomosis that are going to be there. That's why the classification becomes important, because you need to group them somehow to manage similar cases by the same protocol. That's where the grata-causes classification comes in. I'm sure Madam will deal with this in detail, so I'll skip that for want of time. Remember, you have three types based on the grata-causes classification. This again has got to do with placental sharing as well as the number and size of protective anastomosis. If you have mild discordance or plenty of anastomosis, the disease process is mild, which is what happens in type 1. If you have severe discordance and minimal AA, the outcomes are going to be extreme, which is what happens in type 2. And if you have severe discordance, but a large artery-to-artery anastomosis sitting there, that becomes a completely different type from these two. That's what we call as type 3 SFGR, wherein you have a large artery-to-artery anastomosis that is seen there. And what happens when you have a large artery-to-artery anastomosis is that there could be sudden fetal transfusions. If there is even slightest of blood pressure difference from one baby to the other, this acts like an open channel, and therefore there's a large volume of blood that's going to get transmitted from one fetus to the other, and that can lead to sudden fetal transfusion accidents. That's why type 3 SFGR becomes extremely unpredictable, because of this large AA anastomosis that you have there. Lastly, we'll briefly talk in 2 slides about single fetal demise and how is it different from dichorionics and monochorionics. Again, if it's a dichorionic twin that undergoes single fetal demise, because there is no sharing, there's no vascular sharing that happens, this does not directly affect the outcome of the other twin. But if it's in a monochorionic twin set, if one fetus dies, this baby's blood pressure suddenly drops to 0. There are connections between there are open channels between these 2 twins. And therefore, when this blood pressure falls to 0, this baby has normal blood pressure. There's going to be a sudden exsanguination of blood through the AV or AA anastomosis from this twin to the other, and that can cause exsanguination of this twin. So up to 50% of these twins could either die or develop serious neurological morbidity because of the sudden exsanguination that happens, which is why if you compare the outcomes of monochorionics versus dichorionics, once a single fetal demise happens, the risks are much, much higher in monochorionics, just because of these connections that are there. So one twin dies, the other one is bound to exsanguinate in at least half of these cases of monochorionic twins. So to sum up, placenta in monochorionic twins, we are very much clear that the shared placenta is the root cause, as Dr. Bipin sir said at the beginning, is the root cause of all the complications that are known to happen in monochorionic twins. Abnormal anastomosis leads to TTTS TAPS or TRAP. In TTTS and TAPS, it is AV anastomosis, whereas in TRAP, it is an abnormal AA anastomosis. In TTTS, it is large AV unbalanced anastomosis that are the culprits. In TAPS, it is small AV imbalances that are the culprit. And we said in SFGR, it's not the abnormal anastomosis that is the culprit, but it's unequal placental sharing, which is dictated largely by the site of cord insertions. But of course, the natural histories would also depend upon the protective AA anastomosis that are going to be there. So in fact, the natural history of both TTTS and SFGR depends on the protective role played by AA anastomosis. And we said the role of VV anastomosis is still a lot unclear, but it is assumed that in TTTS cases, there are far more VV anastomosis, which could succumb to pressure differences and could function like functional AV anastomosis. Lastly, we said the placental dye injection studies would be the best method to understand monochorionic placenta in greater detail. As I've shown you, lots of cases of dye injected placenta where the final diagnosis becomes very evident. You exactly have answers as to which babies or why certain complications happened in certain babies and did not happen in certain other babies with very similar kind of placental cord insertions, placental territory sharing. The answer lies in the type, number, and size of anastomosis that would have been there, or the difference in the type, number, and size that would have been there that resulted in incongruent natural histories and different outcomes in what otherwise seems to be very similar placentae. So the answer is in dye injection studies. And I implore all of you, when you get monochorionic placenta, there's no rocket science to perform a dye injection studies. You can get these feeding tubes from the NICU, the smallest feeding tube that you can get your hands on. Get those feeding tubes, hold the cord, cut the cord short, hold the cord with a forceps and try and cannulate the artery and the vein. One artery on one side, one vein on one side, and the other artery and vein on the other side. And then use poster colors to try and flush in colored dyes. and then milk out the vessels as the dye goes. Then you'll see that in no time, you fill up the entire vasculature with very flamboyant colors, and then start looking at placentae. That'll give you a very, very good understanding of monochorionic placentae from here on. Thank you very much for your patient listening.
Requesting the chairpersons to say something. That was very engrossing, Dr. Vivek. I had given a 20-minute time, but didn't feel like stopping you because this is the basic of what we are going to discuss in the future. So requesting you to stop sharing your screen and chairpersons to please take over.
Yeah, it was very interestingly explained, though it was such a boring topic and we don't read this topic too much, but we understand the topic so well, and you summarized the topic also very well. And when we understand the pathophysiology, we can manage the cases better. And it was a very nicely explained by Dr. And I congratulate you and I wish you all the best for your further ventures. And we were enlightened by your talk. Thank you. Thank you so much.
Thank you.
Would the other chairpersons like to add something?
Anybody has any questions? Okay, so over to you, Sujaya, for the next session. Thank you, Dr. Vivek. Thanks a lot.
Thank you, ma'am. Sorry for exceeding time. I didn't know there was a 20-minute time.
But we get so much from your talk that it was not, it doesn't matter.
It was honestly very engrossing talk. So
yeah,
it was very, beneficial
very nicely explained.
So I agree with ma'am. So moving on, Mr. Piyush, could you please share the slides? Moving on to the next session, I would like to introduce the chairperson for the second session. We have Dr. Saroj Kumar. Ma'am is the past secretary. She's the secretary of Gurugram Menopause Society, treasurer of
Haryana Obstetric and Gynec Society.
Okay, Haryana Obstetrics and Gynecological Society. She's also the director of Swastik Maternity Center. Ma'am, I would like to welcome you for today's session.
Ma'am is
have Dr. Panchanan sir with us. Yeah.
She's the president-elect of the society.
Okay. So we have Dr. Panchanan Das sir with us. He's the professor in OB-GYN in Guwahati Medical College. He's also the president of the society. He's also the president of Northeast OB-GYN Societies. So welcome, sir, to today's session. Dr. Rajshree Paladi. Madam is the Honorable Secretary of Karnataka Obstetric State and Gynecological Association. She's the Dean of Research of KBN University. She's been the member of Academic Council for KBN University. She has also been the professor in KB NMIS Institute in Kalaburagi. She's presented many papers and guest lectures at various forums. She's also the director and consultant at Aditya Multi-Speciality Hospital. She's received gold medal in OB-GYN. She has been the organizing secretary of the 25th Kasoga State Conference in Gulbarga. She has also been the past president of Gulbarga OB-GYN Society. Ma'am, a very warm welcome to you. I request one of the chairpersons to please introduce the speaker, Dr. Prathima Radhakrishnan. Ma'am, would one of you want to introduce the speaker?
Yeah.
Yeah, please.
Yes, it gives me, thank you very much, Dr. Asha, for having us on this platform and to chair the very important session of Prathima Radhakrishnan, who is a very good friend from Bangalore. And we all know that she's been doing exemplary work in the field of fetal medicine. Dr. Prathima Radhakrishnan is the director of Bangalore Fetal Medicine Center and the FGI Fetal Care Units, director of the FGI Research and Training Institute, Diploma in Fetal Medicine from FMF UK, who is the first Indian to receive this, and Diploma in Advanced Obstetric Ultrasound from RCOG UK. She has held various international posts like the ISUOG Ambassador in India for the year 2021 to 23 and a fellow representative of the South Zone AICC RCOG. She's been the first to perform the therapeutic fetoscopic laser in India. And first to start, on-site and online distance learning blended courses in fetal ultrasound benefiting several doctors across the country. Special interests are fetal diagnosis and therapy, fetal screening strategies, and early fetal diagnosis. She's been an educationalist, offering fellowships, online and on-site distant learning programs, and has been delivered many orations, including the Frontiers in Fetal Medicine at KEM Hospital, Pune, late Dr. Shirodkar oration on the first trimester screening at Solapur, Dr. M.V. Parange oration, reducing maternal and perinatal mortality, is it possible? The first trimester anomaly scan, keynote address at Hubli, and Arnimal Award, Best Presentation, Mahendra Kochar Award, Best Presentation, and performed successfully advanced fetal invasive procedures, pioneered first trimester screening in diagnosis in India, and several international, national, and regional presentations in fetal medicine over 16 years. And her role models are Professor Kipros Nicolaides and Professor Lindsay Allen. And her center is the FMF UK accredited trainer for various certification courses offered by FMF. Welcome to you, Dr. Prathima Radhakrishnan, and we're all waiting to listen to your talk.
Panchanan sir, would you like to say something about the topic while madam is sharing?
Unmute, madam. You have
So
been
please
muted.
unmute yourself, sir.
Ma'am, we cannot hear you. Prathima ma'am, we cannot hear you.
Prathima, unmute yourself, please.
No, she's not muted.
Okay, okay.
There's something wrong with her audio. Panchanan sir, would you like to say something about the topic?
No, madam, nothing more here. Let us continue. Let us continue the session, madam.
There's a slight issue
Having
with
problem in
madam's
sharing.
network, so we're trying to sort it out shortly.
Piyush, can you call madam and help?
Sure, ma'am. 1 minute, please. Ma'am, she's rejoining.
Okay, okay. She joined from the correct link, right?
Yes, ma'am, she joined
I'm
from.
considering ma'am is visible, she joined from the correct link.
She had some issues. I guess she's having some issues with her mic, and it's a technical fault. I mean, it's a hardware problem. She's joining again.
Can you hear me now?
Yes, ma'am, properly.
Audible, ma'am. You're audible now.
I've been using Zoom for a while. Okay, so sorry about that. Thank you very much. First of all, Dr. Asha, Dr. Rajshree for giving that lovely introduction for me. Thank you very much, my chairpersons, for putting up with the little technical hitch that I had. So if you allow me to share my screen, I could do that. And of course, it was a really good follow through to Dr. Vivek's talk. And it's always a pleasure to listen to him. And it sets a nice stage for the further talk, where I'm going to talk about the clinical implications of all that you saw. Unfortunately, you see them before those very pretty injection dye pictures that you see that Vivek shared. And it's a huge, huge, huge learning process. And I always say that managing one monochorionic pregnancy is a humbling experience, to be very honest, because every monochorionic is different from the previous one that you just managed, and the way they will behave is very difficult to predict. Okay, so now let us talk about, we heard from Vivek that there are two fetus circulations. There is one which goes to the twin 1 and one to the fetus 2. But in monochorionics, apart from the two circulations, there is a third culprit circulation, which is the shared circulation. And this is the troublemaker, really, as he beautifully showed in all his injection studies on the placenta that he has done, where you saw all the so many anastomoses. It's not this, it's the middle one, which is the third part of the placenta, which I call the third culprit, is the one which causes the trouble for these poor little things, right? Now, and the other big challenge is the well-being of the fetus really depends upon the well-being of the other fetus. So they are both codependent on each other right through the pregnancy, and therefore they need to be taken care of much, much more closely than in other pregnancy. Now, when we talk about vascular complications, typically the vascular complications are twin-twin transfusion syndrome, twin anemia polycythemia syndrome, TRAP, single fetal demise to some extent, and a little bit of SFGR also, which I will cover, not to that extent. Of course, 20 minutes is too short a time to cover so much in detail. Now, very basics. A discrepancy in amniotic fluid is twin-twin transfusion syndrome. A discrepancy in size is selective FGR. Of course, you can have discrepant anomalies, and a discrepant hemoglobin is TAPS. So we have to be very clear. And of course, they may coexist, but when you see primarily discrepancy in amniotic fluid, we will label it twin-twin transfusion syndrome. Size is FGR and anemia polycythemia is TAPS. Now, about 1/3 of monochorionic twins will develop complications, as you saw, and half of these 1/3 will require some more. Let us look at the first big transfusion. What you see,
Prathima ma'am, would you please come closer to your mic, because your voice isn't very clear. I'm at full volume, but if you move away, we can't hear you.
All right. Is it better when I'm not playing the video?
It's better right now.
Okay, because when I start playing the video, then the volume goes, I think. Is that right? Is it okay?
It's better now. Ma'am, you need to just be closer to your screen.
Okay. So, coming to the diagnosis of twin-twin transfusion syndrome, as you can see, of course, you have a single placenta, you have an oligopoly sequence. That's about it. You don't need discrepancy in size or anything else. Now, the definition of oligopoly is now based on the gestational age. So around 15, 17 weeks, because we start monitoring them from 16 weeks, that is after NT scan, the discrepancy more than 2 centimeters, however, the oligo stays the same, 1 centimeter. If more than 8 centimeters for beyond 18 weeks and beyond 20 weeks, it will be more than 10 centimeters. Okay. Now, this is the criteria that would follow. Call it an oligopoly sequence, right? I can hear some other voices.
Requesting everyone else to mute themselves, please. Piyush, will you please mute everyone who's not speaking?
Okay. So now this is a case which was referred to as Monochorionic twins. Of course, because you don't see the membrane, you see a lot of amniotic fluid. Now, if you actually look at this fetus very closely, you can see the cord is going there. Now, let me just play it back a little bit, right? You can see the umbilical cord is literally hugging this fetus and it just does not move. And normally it will not happen that the umbilical cord is hugging the fetus, okay? If there is fluid, if there is space, the cord will move away from the fetus. And even as I keep trying and, pushing a little bit, the cord doesn't move out at all. And then when you go put the, of course, this is for the color, that's the baby, it's stuck completely. And this is actually a monochorionic twin pregnancy, which is stuck. And this is the membrane, and this is the two layers of the membrane which is stuck together because there is no amniotic fluid in between. So we have to be very careful when we diagnose polyhydramnios, the monochorionic twin pregnancy, and call it a momo twin, which is very likely that it is a monochorionic diamniotic twin pregnancy with a stuck twin, and that requires intervention, of course. Now, the ABCD of any amniotic fluid discrepancy, we have to make sure that there is no aneuploidies or other genetic syndromes. Make sure we check the biometry, look for anomalies, particularly of the urinary tract. Hydrops could be present in one or both, which will indicate a severe disease. Look at the bladders, it could be normal, small, or absent. And of course, in the recipient, it will be enlarged because it will be producing a lot of urine and keep emptying its bladder regularly. Look at the heart, right-sided dysfunction is not uncommon in the recipient of the twins. And of course, look at the Doppler study. So this, I label this as ABCDH of the twins. A standing for anatomy, B for biometry and bladder, C for the cardia, D for the Doppler, and H look for hydrops. Okay. Now, the quintillion staging will help us to understand or communicate the level, the staging of the bladder, and of course, decide about the management to some extent. And there are 5 stages in which once you have detected there is the discrepancy in the fluid and that there is twin transfusion, if you see the bladder and the Doppler is normal, it becomes stage 1. If you do not see the bladder, and of course in the donor, because the donor is the one where the bladder will not be visible, and Doppler continues to be normal, it is stage 2. Of course, when the Doppler becomes abnormal, and that could be the umbilical artery Doppler in the donor, but also the cardiac Doppler in the recipient, it becomes stage 3. If you see high drops in one or both, it is stage 4. And of course, if one or both the fetus are dead, it is, it is stage 3. Now, of course, you can have atypical presentations. Although we grade them as 1, 2, 3, 4, 5, it is not at all, necessary for 1 to progress to 2 to progress to 3. You can jump from 1 to 4 or 2 to 5 within no time sometimes, right? That is why I said every monochorionic pregnancy is different and it's a humbling experience each time, right? Now, looking at the heart of the baby, because this is also a vascular, you can have severe tricuspid regurgitation, AV valve incompetence because of the overfunction or the overburdening of this heart, if you will. And however, this tricuspid regurgitation does not necessarily indicate the progression of the clinical outcome, because we have seen in babies which have had tricuspid regurgitation, where they have done the laser, the tricuspid regurgitation has reverted back over a period of time. Of course, in utero healing, anytime is anytime better than ex utero healing. Okay. So you can have maternal symptoms also because of the overdistension, and you can have mirror syndrome also, where the mother also starts developing swelling in the legs and hands as well. Apart from that, cervical shortening is very, very important. Look out for
फिर चम्मच गुड़ लिया, चल 2 चम्मच मिक्स कर दिया, वो तेल में तो ठहरे ही नहीं, बिखर गया क्योंकि उतना सारा नारियल सब था।
Thank you.
Kataran.
Okay, so premature fetal shortening is a very, is a very difficult situation because of excessive fluid. The cervix can start shortening, and of course, this is linked to the possibility of preterm
So,
outcome of the pregnancy. And certainly, cervical circlage has not shown to be of any benefit. So, and if at all it has to be done, it is always preferable to do it after the laser procedure, if at all necessary, because if we have a cervical stitch in addition to you have to do an fetoscopic laser, then the risk of infection and preterm delivery also goes up significantly. So my request to the obstetricians is, in monochorionic twins, better to avoid putting unnecessary cervical stitches and save them for later if at all it's necessary, because you don't know which way this pregnancy is going to go. Now, coming to the management of twin-twin transfusion syndrome, of course, there is expectant management and fetoscopic laser. Although I don't do amnioreduction, that is an option, but in much later stages. And of course, selective fetal growth restriction if there are additional selective FGR, and this depends upon various stages, the Quintero staging, the maternal symptoms, gestational age, and of course, the availability of expertise. Now, in twin stage 1 Quintero TPS, most of the time it's expected management. So once you've diagnosed stage 1 TPS, we heard that half of them will remain as they are, but the other half can progress. So we put them on weekly scans. About half of them can progress, and of course we avoid amnioreduction in these cases because it can actually worsen the outcome of laser if at all we have to do. However, in stage 1, sometimes when extreme maternal discomfort or shortness of the cervical length, then there have been times where we have performed a fetoscopic laser. And of course, in uncomplicated monochorionics, they continue at stage 1, and it's very, very reasonable to deliver them at 37+ weeks, giving the baby the full chance to grow in utero. In stage 2, 3, and 4, and of course, symptomatic stage 1, we would go with fetoscopic laser, which has definitely shown to increase the double survivors, increase the single survivors, reduce the double IUDs, and most importantly, give them a better gestational age at delivery. The two most important challenges that we face is preterm delivery, and of course, we need to avoid that. And therefore, the request to obstetricians is that when a fetoscopic laser has already been performed, the aim should, and the placenta has effectively been dichorionized, the aim is to try and push the pregnancy as late as possible so that we can deliver them to as close to term as possible. Because one of the main reasons why we perform fetoscopic laser is to prevent preterm delivery. The other challenge is single fetal device can happen after fetoscopic laser, and again, because we have already kind of dichorionized the placenta, this will be managed like how we would manage a single fetal device in a dichorionic twin pregnancy. Now, if IUD happens post FLA, what are the neurological problems to the survivor is less than 2%. That, as I mentioned, is the same as in dichorionic twin pregnancy. Do we deliver them immediately? Absolutely no. Do we check the middle cerebral artery Doppler, look for anemia, because sometimes there can be anemia. And also, you remember, there were small anastomosis that is not sometimes visible during the fetoscopy, or even they can generate later on, or some which are deeper anastomosis, which is not obvious on the surface of the placenta, can cause anemia, and that can present later. In that situation, we would obviously transfuse the baby if required. We continue to monitor the growth and fetal well-being, maybe consider an MRI, but of course, with the aspect of good neurosonograms, prenatal neurosonograms, I think that is good enough. And if you're suspicious, then go ahead to do a MRI. And of course, we deliver them as per single norms. Follow-up is very, very important, looking at the amniotic fluid, looking at the Doppler, checking the growth, and of course, the cervical length as well. Coming to the second patient, polycythemia syndrome. Now, in this, there is a severe anemia, hemoglobin discrepancy, not necessary at all to get oligopoly. You may get some polyhydramnios in the anemic fetus because of diuresis, but not necessarily the type that you would see in GGTs. Of course, there is with the chances of developing TAPS post fetoscopic laser is about varies from 2 to 10%, whereas it can happen spontaneously also. Right? Now, how do we diagnose? Diagnose simple way of diagnosing, like how we diagnose every middle cerebral artery Doppler and look for anemia and polycythemia and plot them. And of course, they also have staging. Now, the other very important thing is looking at the placenta. You can see that there's a hyper-echoic part of the placenta and there's a hypo-echoic placenta. The homogeneity or the echogenicity of the placenta is different. And the hyper-echogenic placenta is the donor placenta or the anemic placenta, whereas the hypoechogenic is the recipient side of the placenta. So you can start suspecting the possibility even as you start scanning the fetus. So in this donor baby, which this is also donor in TAPS and recipient in TAPS. Okay. Now, how do you evaluate? They also come with 5 stages. In the first and second stage, the discrepancy is more than 1.5 MOM and less than 1 mm, exactly like how you convert we use the perinatal calculators. There is no fetal compromise. If you start having Doppler changes, then it becomes stage 3. And if you have high drops, it's stage 4. And if you have demise of one or both, it's stage 5. Right? How do you treat them? Expectant management, because some of them can resolve on their own, but you monitor them very, very closely. You may, if they are post 32 weeks, you may consider delivery and treat them both. You may do laser ablation again, or you may do a fetal reduction if the situation is remote from delivery, or you can even do an intrauterine transfusion. I do tend to do intrauterine transfusion, but it varies from baby to baby for the anemic fetus. And I heard from one of my colleagues who has done bloodletting of the other fetus. I have not done it personally, but I need to do it. But this is not very common scenario that we see post laser therapy as well. Now, just a word about selective FGR. It does occur. It's not an infrequent complication in monochorionic twin pregnancy, and there is a definition for the same as well, where the estimated fetal weight of one fetus is less than third centile or 2 out of the 4 criteria as well. And the discordancy is calculated by the larger minus the smaller divided by the larger. And this is primarily because of the unequal sharing of the placenta. But in this also, velamentous cord insertion is notorious to cause SFGRs as well. But why I brought this topic in this vascular part is because of this, because you can have type 1 when you're good, and it is divided into type 1, 2, 3 based upon the umbilical artery Doppler of the smaller baby. Okay. Now, if you have good umbilical artery blood flow, of course, you have positive and diastolic flow in all the cycles, and it is important to Doppler these babies for a slightly extended period of time. At the beginning of the scan, middle of the scan, end of the scan, again come back and Doppler them a few times, because you can sometimes get confused between type 1 and type 3, because even in type 3 you can see that sometimes there is positive end diastolic. If you have absent end diastolic flow all through, then it is type 2, and if there is intermittent, then it is type 3. Type 2, of course, has got a much poorer prognosis than type 3, and type 3 is unpredictable, and that's a problem. So you will manage them based upon what gestational age you're seeing and how much is what is the umbilical artery blood flow. Now, in type 1, generally, you continue monitoring them weekly because you're seeing a discrepancy, because the moment you see discrepancy in monochorionics, the monitoring has to become weekly. If there is no discrepancy, it's fortnightly. So if there is worsening Doppler, which can happen in about 25%, you increase the surveillance and, of course, talk about intervention. If they are stable, then you can carry on till 36 weeks and then deliver them at 36 weeks. So if there is worsening Doppler, even in stage 2, type 2 and type 3, if it is pre-viable, then you would consider doing selective fetal reduction. If they don't want, then you, of course, continue surveillance and deliver them at 32 weeks. And if they accept a selective fetal reduction, then we continue them as singleton. This is what we follow as well. And of course, if they are single fetal demise, unfortunately, sometimes it can happen. Then you also continue the pregnancy as singleton demise. Now, complications in monochorionic twins and selective selective IUFT can happen in any of these scenarios, whether it is TTTS, whether it is FFGR, whether it is TAPS, and it can happen very suddenly without you knowing. 1 week it is fine, and next week the baby is dead. Now, unfortunately, these mishaps happen, and these are probably vascular related as well. Now, what do we do? It's a huge challenge, because if this happens before performing the laser or before dichorionizing the placenta, then the risk for the surviving twin for prematurity and other neurodevelopmental problems is significantly high, right? And therefore, the tendency or the push from the parents is to just deliver the other baby also, but we have to resist that, because if we deliver a baby that is likely to be neurodevelopmentally delayed, premature, we are adding prematurity on top of another problem, and that is not right. So if there is no obvious cause, maternal cause, or no need to deliver, there's no hypertension, no other reason to deliver the pregnancy, we would just prolong the pregnancy and continue with weekly scans. And if there is any brain anomaly, then brain changes, then consider doing an MRI and counsel the parents properly as to what is the likely outcome of this pregnancy. And of course, if there is already evident brain damage with penileucomalacia and things like that, then we may consider termination of pregnancy, because then the prognosis for the baby is very poor. So primarily, it's the gestational age which will determine the management, and chorionicity determines your outcome. What happens in TRAP? TRAP, as you saw, there is one amorphous twin and the other one which is structurally normal, which is the pump twin, and it is feeding the amorphous twin which continues to grow. So obviously, this is not normal, and this needs to be reduced. And there is enough evidence now that if you reduce them early enough, then the chances of having a good outcome and continuing the pregnancy as a singleton pregnancy is much, much better than continuing with TRAP, right? We did a small study, a retrospective audit of the TRAPs that we had seen, and we published this in 2020, about 13 monochorionic TRAP pregnancies that we had followed. And we just observed, in half of them did laser, the other half didn't do laser, and in the half that went on just expectant management, we had only 2 live births, whereas in the group that we did the laser at different times, as they were referred, we started doing them, we had 100% live births. So this is just an audit of our what was happening in our own scenario, but I think subsequently there are many papers which support now intervention in TRAP. So the moment you diagnose TRAP in the first trimester, confirm the chromosomal, do a CDS, check the chromosomal array, and once that is confirmed to be normal, because about 4 to 10% of TRAP sequences can have chromosomal aberrations also. Therefore, it is important to check that before we do a therapy for them. And finally, Momo twins. And again, Momo twins in the same sac. We can pretty much diagnose them at 12, 13 weeks. I would not diagnose them earlier than 12 weeks, because sometimes the membrane is so thin that you will not be able to see it before 10 weeks. Therefore, it is always best to wait for 12 weeks and then diagnose it. The membrane and entanglement, non-entanglement is almost always present. By 16 weeks, almost all cords are entangled, because of course the baby is going to move around with its condition, right? So we need to panic when we see something like that, and this is only 17 weeks. Surveillance will be like any other monochorionic diamniotic twins, and realistically, there are any complications, and majority of them will be delivered by 34 weeks, because that's the current recommendation. Okay. Now, what can be misleading is misleaders are twin fetuses. As you already know, that there is nothing called twin fetuses. You have to mention the chorionicity. There is nothing called as a single fused placenta. It cannot be a single fused placenta. You have to define whether this is a monochorionic placenta or this is a dichorionic. Right? You have to define the lambda and the T sign And of course, beware of the monoamniotic twins, because the membrane can be so thin, sometimes you have to increase the bleed and then see the membrane. Because if you work under low bleed while you're doing your routine scan, you may not even see the membrane there at all, and not incorrectly label it as monochorionic monoamniotic. So you have to spend time for these. So uncomplicated twins, go ahead and deliver them at 38 weeks. What is the big rush? In complicated twins, of course, it will be decided by the normal fetus. But in complicated monochorionic twins, I think it's very, very important to work together with a fetal medicine specialist who can guide you through what all to do. And most importantly, avoid a preterm delivery of a normal fetus, because irrespective of how much ever we talk about the complications, prematurity is still the single most important mortality and morbidity factor for these small babies, irrespective of whether they are singletons or twins or multiple pregnancies. Thank you very much.
Thank you so much, ma'am. Over to the chairpersons for their comments. Would you please stop sharing, ma'am?
Yeah, I will. Stop.
Thank you, Dr. Prathima Radhakrishnan, for your beautiful presentation on the topic. Twin pregnancies are very much challenging, involving obstetrician, radiologists, as well as fetal medicine specialists. In some places of India, we don't have the facility of fetal medicines, but your lecture will be definitely be helping many of the people. And at the end, I thank Dr. Asha for allowing me to have your atmosphere. Thank you, madam.
Thank you, sir. Thank you, Prathima, ma'am. Thank you so much. Should we proceed with the panel, Sujya? This is a request to my respected panelists. We have heard everything. So now I have 10 cases, but those 10 cases, each one has 1 or 2 important points that need to be brought out. The answers have all been given by the first 2 lectures. So we just, have a quick run in, because learning the theory and then seeing the case and deciding what to do about it are 2 different things. So I'll share my screen and we'll start the program. So the panel is on monochorionic twin pregnancies. We have 10 cases. Each has questions, but each has a particular point. And when I'm presenting this before you, to my panelists, think of it from the obstetrician's point of view. And we have 2 fetal medicine specialists as our experts. So they will give their inputs about the special thing about the fetal medicine part. That's me. I'm going for Chairperson, Food, Drug and Medico-Surgical Equipment Committee, election year 2024. I request all of you, please nominate me from your societies. The nominations will be in May and the elections will be in August. So these are my panelists and experts. We have Dr. Vandana Bansal ma'am, who's kindly consented to be an expert. And she is an obstetrician and super specialization in fetal medicine and interventions. She has 28 years of experience in obstetrics and gynecology, including 23 years in fetal medicine. She does a lot of fetal medicine work. She's an additional professor, obstetric gynae and head of ultrasound department. She's also going for perinatology committee this year. So welcome, Dr. Vandana ma'am. We have Dr. Vatsla Dadhwal ma'am, who's the professor and unit head, Department of Obstetrics and Gynecology, AIIMS, New Delhi. She has an interest in fetal medicine. many papers, many presentations, and a lot of work in fetal medicine. Welcome, ma'am. These are our fetal medicine specialists who are our experts. And now we have our panelists, Dr. Revathy. Dr. Shri Revathy Sadasivam, ma'am, is the president of Erode Society. She may or may not be able to join because there's a sudden inspection in her college. We have Dr. K. Gokul Priya, ma'am, from Kilpauk Medical College, who is the vice president of Erode Society. We have Dr. Garima Sharma, ma'am, who is the secretary of Firozabad Society. We have Dr. Ira Vishwas from Guwahati because Dr. Kalpana Choudhury had a death in the family and could not join. Welcome, Dr. Ira. Neeru Thakral, ma'am, is with us. She is the secretary-elect of Gurgaon Society. She's also an IVF specialist. We have Dr. Anushree Pal, who's the secretary of Haldwani Obstetric Gynec Society. Young, dynamic secretary, loves dancing and reading. We have Dr. Renu Sethia, ma'am, who's the director of Bombay Hospital Maternity Home. And she is the president of Hanumangarh Society. Dr. Prerna Rathore, madam, again from Hanumangarh, she's the secretary. And we have Dr. Dharani N, who is the secretary of Erode Society. Welcome all my panelists. And now we start. This is the first case. We have 40 minutes on this panel and we have 10 cases. So we are roughly taking 4 minutes per case. So this is a 24-year-old Gravida 1. She's 22 weeks. When the mid-trimester anomaly scan was done, the radiologist said that it's suspected TTTS. So what are the common complications associated with monochorionic pregnancies? Panchanan sir, would you please mute yourself? Dr. Garima?
Yes, ma'am. So, ma'am, there are complications which are like specific to monochorionic pregnancies, like the twin-twin transfusion syndrome, the twin anemia polycythemia sequence, the TRAP sequence, then selective fetal growth restrictions. Also, single fetal demises, they are more common in monochorionic pregnancies and they are more deleterious also. Also, in monochorionic monoamniotic, the conjoined twins is a specific complication. But otherwise, if we talk of common complications, they are the same in all twin pregnancies, irrespective of the chorionicity. So,
okay. Yeah. So now, how does selective IUGR impact monochorionic pregnancies?
Ma'am, please go to last case. Last slide.
Sorry. So how often does TTTS occur? Dr. Neeru? How often does TTTS occur?
In monochorionic, chances are 15 to 20%. There may be chances of twin to twin transfusion, 13% roughly.
So what are the diagnostic criteria?
When on the ultrasound examination, deepest vertical pocket in the donor, if we see the Leica is less than 2 centimeter, and recipient, when the deepest vertical pocket is more than 8 centimeter, lesser than 20 weeks, and more than 20 weeks, we take it more than 10 centimeter. Then we diagnose it as a TTTS.
Okay. So if one baby is lost in a case of TTTS, intrauterine demise is there, what is the risk for the surviving fetus? What is the risk for the surviving fetus?
There may be neurological deficit in few percent, but that doesn't mean that it may be in all the cases. That's why we need a fetal medicine specialist, and it's a multidisciplinary approach. We have to monitor them and we have to counsel them. There may be chances of neurological, but we don't have to monitor for the DIC in these patients.
So, ma'am, what are the challenges in optimal timing of delivery? The baby has TTTS and it's a monochorionic twin pregnancy. So, what are the challenges in determining the timing?
So we have to deliver them early, definitely 34 weeks nearly we have to deliver. It depends upon the Quintero staging, like which stage it's and what are the Doppler finding. Accordingly, we have to manage them at 32 or 34 weeks, depending upon what are the staging, what are the Doppler finding. We have to monitor Doppler properly. We have to see the MCBA, umbilical Doppler, everything. We have ductus venosus, see the Doppler finding, NST. If there is deterioration in the NST, there is no beat-to-beat variability, or if there is reversal of the flow, then we have to do immediate delivery. Otherwise, we can carry them by 32 or 34 weeks.
Vatsla, ma'am, would you like to add something here? Because MC twins has specific challenges. You're muted, by the way. You're muted, ma'am. Vatsla, ma'am.
So good evening, everyone. Thank you, Dr. Asha, for inviting me for this panel discussion. So one thing, like for any monochorionic twin pregnancy, whether it is case of TTTS or otherwise, if one twin dies in utero, there is a risk of the surviving twin dying in up to 15 to 20%, and the risk of neurological damage is also equally high. So that is one challenge here. And many times they would like to do a MRI after 3 to 4 weeks to see that the surviving twin doesn't have a neurological damage. About the timing of monochorionic twins, if it is a stage 1 TTTS, and actually if you like, it may remain stable. Like maybe half of them would progress, half may remain stable. So we'll have to actually monitor and see how the growth is going on, how is the fetal well-being, and see how long you can pull on the pregnancy, maybe 32, 34, 36 weeks. Advanced stages of TTTS, if you don't treat, they're likely to land up in preterm labor because of polyhydramnios or IUD in one or both twins. So anything beyond stage 2 or more, ideally we should treat TTTS by laser, like Dr. Prathima has already told us. And in stage 1, if there is excessive polyhydramnios or short cervical length, we may also treat these patients with laser. Otherwise, the prognosis is not good in these twins.
What I understood from Dr. Vivek and Dr. Prathima Radhakrishnan was that you don't want the child to die for you. You want, either it should be selective feticide or you want them both alive. So that is the point that we are going to consider when we are trying to deliver the babies. So just one outlier question for you. When would you consider feticide? It's a baby of TTTS. When would you consider selective feticide?
So we'll have to counsel the couple whether they want to continue with one pregnancy or both. And if it is like maybe a technically difficult case in which the placenta is anterior, not reachable, then you may consider doing a feticide. Otherwise, you can do laser photocoagulation also.
Yeah, so actually even laser coagulation would be, you're saying laser coagulation of the placenta, right?
Yeah, if you want both the babies, then you can do laser photocoagulation of the anastomotic vessels so that each, like divide the placenta into 2 to avoid the complications. But if the procedure is technically difficult or, one baby is compromised and the parents want to continue with one pregnancy, then the option of selective fetal termination is also there.
Thank you. Thank you, Dr. Vatsla. Thank you. So now we are to the next case. This is a 38-year-old IVF pregnancy. She has MC-DC twins. And the difference in the estimated fetal weight is 40%. So how does this selective IUGR impact monochorionic twin pregnancies? Dr. Kalpana?
Yeah.
Dr. Anushree?
Yes, ma'am. Hi, ma'am. This is Dr. Anushree here, ma'am. Thank you. This was a very well-organized lecture, and thank you for giving me this opportunity. Ma'am, selective IUGR growth restriction will impact monochorionic pregnancies in the way that one of the twins is 20%, more than 20% discordant in growth. And because of that, the twins may develop, there may be risk of early fetal demise, or there may be, even when they are delivered, then there may be perinatal mortality, perinatal morbidity, and even delayed neurological milestones in these pregnancies.
So, what are the ultrasound findings that suggest that there is selective IUGR?
First of all, ma'am, there is a discordance in the growth. That is, we calculate the expected fetal weight of the larger twin minus the smaller twin upon the largest twin into 100. That is how we calculate this. Then we also see the umbilical artery Doppler, and that is how we categorize this into various stages. In the first stage, there is abnormal in the first stage there is abnormal umbilical artery waveforms, but there is no. And the second stage, there is a reverse or absent end diastolic velocity. And in the third stage, there is cyclical change. So obviously, type 2 SGR is the most severe form of selective growth retardation. And we can also see the Leica volumes, though, especially when if it is associated with twin transfusion syndrome, it might be associated with twin transfusion syndrome and other complications of twin pregnancies. So we must assess the Leica volume, and at times ductus venosus velocity, as well as CTG findings, and this all can determine the time of delivery, madam.
Anushree, you are the obstetrician, right? Vatsla
Yes.
ma'am has conveniently said that you let the parents decide. Now the
Yes.
parents are asking you that, if we keep both the babies, then what are the long-term outcomes for these babies? Because you give us the options, only then we can decide, right? The parents don't have enough information. So what are the
Ma'am, of course, we can tell them that after delivery, we can tell them that if you keep these babies, if you continue with this much of discordant growth, first of all, they should be referred to a higher center, and they should be ideally advised by a fetal medicine expert, I must say, especially if it is more than 25%, the recommendations say that we should refer.
40% here. It's 40%.
Yes, and it's 40% here. So we must tell them that a fetal medicine expert will be able to guide them better, especially if it's an early onset IUGR. We must say that we must advise them for selective fetal reduction if possible. And if not, ma'am, if they are ready to keep the babies, we must tell them that there is a high probability of early fetal demise. And even if the babies are delivered normally, there is a fair possibility that when they grow up, they may have all the maladies of IUGR which we have. They may have delayed developmental milestones. They may have severe cognitive as well as neurodevelopmental abnormalities, as well as, of course, risk of preterm delivery, prematurity, which in cases of complicated deliveries, we have to, in case of severe IUGR, we have to deliver them at early, say 32 weeks to 34 weeks. So all this has to be explained. It is a multidisciplinary approach. A neonatologist should be available.
Interrupt you for a minute. May I interrupt?
Yes, ma'am.
Vatsla ma'am, I would like you to give your opinion here.
Dr. Asha, you were
It
depends on what is the gestation also. So there is
she's 22 weeks.
So okay, so there is SFGR, and there's so much of discordancy of 40%, then the option of selective fetal termination is there. We can offer them, especially if it is type 2 or type 3 SFGR.
Otherwise, they are asking you, that what is the outcome? If we allow them to grow, then what's going to happen to the baby that is not growing for the growth restricted twins?
So if we let the pregnancy continue, so we have to monitor these babies if they reach viability, and then the pregnancy outcome is determined by the smaller twin. So whenever the smaller twin is compromised, you may have to deliver the pregnancy prematurely, because if this twin dies, and if the fetuses have reached viability, because if the smaller twin dies in utero, the normal surviving twin has a risk of 15 to 20% of fetal death or neurological morbidity. And there is a very high chance, even like if it is stage 1 SFGR, then the prognosis is better. But again, with so much of discordance, it is very likely the smaller twin would have compromise and may require preterm delivery. And if it is type 2 and 3, then the last chances of deterioration in the smaller twin is much earlier, so it requiring preterm deliveries, and the risk of one twin dying in utero. And sometimes even if both twins survive, there may be risk of neurological damage in the normally growing twin also, especially in type 3 SFGR. Ma'am, you're muted.
If there is a trap sequence, you've seen it already at 12 weeks. So what is the potential risk for the pump twin? Are you going to do an umbilical cord section, or are you just going to wait it out that nothing will happen? Ma'am, that's my question to you. Vatsla, ma'am.
Okay. So if we have a trap sequence, we usually go for a fetal reduction. We reduce the trap twin, because if you leave the pregnancy, then there are higher chances of the normal twin having polyhydramnios, going into congestive heart failure and dying in utero. And some people would wait for the features of compromise to develop in the normally growing twin, but we electively reduce the trap irrespective of the status of the other twin. At what gestation you should do the reduction is also debatable. Since we're using radiofrequency ablation, we do the reduction around 14 to 16 weeks. But again, if you're waiting, there's a risk that the trap twin may die in utero, and there may be risk of, fetal transfusion at that time.
Dr. Ira, would you like to add something? You're muted, ma'am. Dr. Ira, you're muted.
Yes, thank you, ma'am, so much for giving me this platform. Actually, the age of the period of gestation is important. And in case there is a trap syndrome, we have to be very diligent about taking the decision, because the good twin, the pump twin, is at more risk of heart failure. Then the twin is at a more risk of polyhydramnios and also hydrocephalus and also growth restriction at the same time. So we have to be very diligent that what is the time of termination, when shall we terminate, and consider selective reduction of the other twin. And regarding this case where we have already found there was a difference of 40% EFW, I think we shall counsel the patient. If it is a term pregnancy, we can deliver both the twins and counsel for a better management in a higher Nico-Pico setup. I think that way we can manage this case.
Okay. Dr. Vandana, would you like to add something to this, or we go to the next case?
For this first case, which you are showing case 2, where there's a discordancy of 40%, it's the gestation who will decide. So if the gestational age is somewhere around 28-30 weeks, then we have an option in the patient parents whether the sizes of both the babies are how much the NICU survival in your institute. But if it is something like 22 weeks, then the chance of this growing and both of them being salvaged is very, very poor. So for a 40% discordancy, if the Doppler is very bad at 22 weeks of gestation, I think the choice should not be left with the parents, because here we are obviously thinking that the baby is going to die and have a problem to the other baby. And so there may be a reduction by radiofrequency ablation can be done. For trap, what Vatsala is saying is correct, that there is a lot of controversy whether we do it for the ones which are big size traps or whether we do it once it starts compromising. But the new consensus is that all taps have to be, the trap has to be all reduced. So all of them are, earlier were doing at 14 weeks and now 16 plus is what we do. So you need to do reduction for all the traps, whether the size is small or not.
Thank you. Thank you so much. So now we are quickly going to the next case. It's a Gravida 2 para 0. She has had 1 abortion. She is diagnosed MCDA twins. One sac is showing scanty liquor and the second has polyhydramnios. And this is 30 weeks. Okay. So what is the significance of chorionicity and amnionicity that I think we have discussed? So what is the implication? Another question for the experts. You know, how do you differentiate between a TAPS and a TTTS?
So Vatsala, you want to take it or I?
Please go ahead, Dr.
So TAPS happens as what I think Vivek has also spoken.
Actually, Dr. Vandana, I'm not going about the theory.
Yeah, I'm talking
when
about
a gynecologist sees the report, then it is TTTS or it's TAPS. What is the difference that they are going to see?
So in TAPS, you will not have an oligopoly sequence. Oligopoly will only happen in a TTTS. In TAPS will only be picked up if you look at the MCA PSV. So only when you have done an MCA PSV and there's a discordancy. So one, if it is 1.5 and one is 1 mom, so there's a discrepancy in the velocity in the MCDA. In middle cerebral artery, then you will call it as TAPS. So TAPS will usually not have oligopoly. It will not have bladder discrepancies. It will not have any of the findings of TTTS. The only finding of MCA discordancy.
Thank you so much. I wanted that, us obstetricians reminded of that, because, once you start listening about the placenta, you end up getting all muddled. So this case 3 is with
this one line I would like to say. So any monochorionic twin pregnancy, after the NT scan, we have to follow every 2 weeks for development of these complications. So every 2 weeks, we're looking at the Lie curve. If there is oligopoly developing, then we have to look at the bladder and the Dopplers to stage for TTTS. And from 16 weeks onwards, we also do MCA PSV for TAPS. And we're also looking at the growth, because SFGR can set in very early in monochorionic twins, as early as 16 to 18 weeks. So every 2 weeks, we have to look at all these things to rule out one of the complications.
Okay, thank you. Dr. Gokul Priya, you are here?
Yes, ma'am.
Yeah, would you like to add anything to this case?
That's it, ma'am. As ma'am said, we need to diagnose it with the help of the difference in the amniotic fluid. As a general obstetrician, we have to look for that. And if at all, whenever we find this oligopoly sequence, we have to think in terms of TTTS. And with the help of the fetal medicine specialist, we need to grade them and also look out for the other complication which can eventually start in, like that of the selective growth restriction and the TAPS.
Okay, so thank you. Thank you so much. Now we are on case 4. This is Gravida 3 para 0. She has previously been diagnosed MCMA twins, monochorionic, monoamniotic. One fetus is large, other is small. So is this an IUGR or a vascular complication? You are not seeing any change in the Dopplers or anything. It's just a discrepancy in size. This is at the mid-trimester scan. So this is Dr. Anushree, Dr. Dharani, Dr. Prerna. Anyone can join in and answer this. Dr. Dharani?
Yes, ma'am.
Yeah.
Ma'am, we want to, we can go for a Doppler, and in the Doppler we can. Doppler is used for the key diagnosis of specific conditions like TAPS and selective IUGR, fetal anemia and all. So it is also used in grading the severity of the complications. In
TTTS, which is the specific vessel that you want to see?
Umbilical artery.
Okay. So what happens to the umbilical artery measurements?
In the umbilical artery, there is the recipient twin PA will be.
बहुत बड़ा लंबा है यार.
वो आपका काम हो गया तो हटा दो. Hello.
Yes.
Ma'am, umbilical artery, the PA of the recipient twin will be more. It will be around more than 0.5 greater than the normal range.
Okay. And anything else?
Umbilical artery will have initially absent flow, then there can be even reversal of the flow in the later stage. And when we do middle cerebral artery PSV, there may be donor twin maybe have more than 1.5 MOM and recipient till may have less than 1 MOM. So that
one thing is, what are we seeing that now this compromise has started? What are the parameters that will, when you read that report, what are the parameters that tell you that this twin is getting compromised?
umbilical artery PI, if it's less than 0.8 or less than 1, depending upon the gestation. Like if it's 28 week onward, less than 1 or less than 0.8 weeks, 0.8, or if it's at the 20 weeks, then it's less than 1 or 1.2. Or when we see the MCA, it's more than 1.5. So Doppler is very, very essential. After 2 weeks, everyone gets the ultrasound, but Doppler is very essential parameter in all this monochorionic after
How
every
often are you going to check for growth? And how often are you going to check for Dopplers?
2 weeks. Growth Doppler along with the Doppler. And if we have treated any taps, then initially we check every 1 week till 2 weeks. After that, again every 2 weeks.
My experts, would you like to add something, please?
So in this patient, which is an MCMA twin, you have said. So that means the Leica discrepancy will not be there at all because there is only one sac. So the first stage of twin to twin is oligopolysequence, which cannot be picked up in an MCMA, but MCMA can have TTTS. So how do we see? Let us go to the second stage. So the bladder discrepancy can be seen even in an MCMA. So if I see bladder discrepancy in an MCMA, although the Leica is going to be same, I will call it as stage 2. And what you are saying, how do we see worsening? So stage 3 is Doppler discrepancy. So usually the donor will have high or absent umbilical artery and the recipient will have DV reversal. So you have to look at umbilical artery as well as DV for TTTS discordancy, and for stage 4, you will see high drops in one of them. So in MCMA, the first part is not picked up. Stage 2, stage 3, stage 4 will be picked up. And if you see high drops, it is stage 4. And if there is death of one, it is stage 5. So it is very well defined. And in all of this, we also look at cardiac dysfunction. So a cardiac dysfunction, if I see, then any stage can jump from stage 2 to stage 4, or from stage 1 to stage 3, or it may remain the same. So cardiac dysfunction also we look at in all the cases of TTTS. MCMA is interesting because you will not see the oligopoly.
Thank you, ma'am. Thank you so much for enlightening us. Now, my very basic question. Dopplers you are going to do weekly or maybe in 2 weeks. But for growth, what is the frequency that you require of an ultrasound? Dopplers are something else and growth is something else. So for growth, what is the frequency? And for Dopplers, what is the frequency? Vandana, ma'am.
Yeah. So for Dopplers, if it is worsening, we will do it every week or even more frequently also. But growth has to be at least more than 2 weeks. So if there is a discordancy, you will monitor it every 2 weeks. But for Dopplers, you might want to do it early depending on what is the status of the umbilical artery. If it is high, I will do it weekly. If it is absent, I might do it bi-weekly also. So growth, but
actually for growth, the guideline says 4 weeks. Minimum 3 weeks. Minimum 3 weeks for growth. And Dopplers are as per.
Yeah, but you're talking about monochorionic twins. So for monochorionic twins,
every 2 weeks.
Every 2 weeks.
Every 2 weeks.
Singleton, you're right in saying at least 3 weeks you have to have between 2 scans to see the growth.
Okay.
Yes, ma'am.
So now we
proceed. We can up to 4 weeks, but here monochorionic we always see every 2 weeks.
In monochorionic, you have to scan every 2 weeks for sure. But what are the parameters that you're seeing on each scan? There are NICE guidelines. There are also ISWAG guidelines. So different things are measured in different scans. Scans are done every 2 weeks. That is for sure. So now this is a 26-year-old para 1. She's diagnosed MCMA twins at 12 weeks. Now, what are the considerations of management? She has just been diagnosed MCMA twins. What are the maternal complications associated with monochorionic twin pregnancies? Dr. Gokulshree? Dr. Garima? Dr. Venu?
Ma'am, in monochorionic twin pregnancies, mostly there is an increased risk of interventions for management of conditions like the TTTS and congenital anomalies.
I'm talking of maternal complications. If there is a twin pregnancy, what are the maternal complications?
Ma'am, irrespective of chorionicity, we can have maternal complications like maternal anemia, increased incidence of PIH, preeclampsia, gestational diabetes, also antepartum hemorrhages because of placenta previa, vasa previa, increased operative deliveries, postpartum hemorrhages. But specific to monochorionic pregnancies, there might be increased risk of interventions to deal with complications like the twin transfusion syndrome and congenital anomalies. Also increased operative delivery incidences there.
And preterm labor.
And preterm labor, yes, ma'am. So is there a risk of TTTS recurrence in subsequent pregnancies? This is a very basic question that the patient will ask you. कि दोबारा twins हो गया तो क्या फिर से हो जाएगा? So what do we answer? Is there a risk of TTS recurrence in subsequent twin pregnancies?
Ma'am, I couldn't find any data regarding this in subsequent pregnancies, but
that is for our experts, ma'am. That's for our experts. They'll answer us.
No recurrence.
No recurrence.
What would be the chance of a woman again having a monochorionic twin pregnancy? Would be very rare. I mean,
So
and the
no
chance complication.
You know, anybody can ask you any question.
Yes.
So this is a counseling that this is something which is not going to be recurrent. So then the decisions are mostly taken by the parents depending on what comes out. So TTTS, you can't have unfortunately twice monochorionic and then unfortunately twice TTTS. So
very, very rare. Yes.
Yes.
So if there are pre-existing maternal conditions, do they alter or influence the management of monochorionic twins?
So mostly maternal medical conditions, they get deteriorated in case of twin pregnancies, and iatrogenic preterm deliveries, they happen because of pre-existing maternal conditions.
So if there is hypertension or diabetes or previous history of preterm, then in a monochorionic, I will be worried about all this more. So because the interventions are going to be more in these cases. So maybe my counseling will more tilt towards, let us do one reduction for one of the baby by laser or by RFA or by bipolar. So yes, it will affect if it is a primigravida, no risk factors, then maybe I can tell the risk of MCMA and go on with the pregnancy. But if it is a 45 years or a hypertensive or a diabetic or a previous history of preterm or previous 2-3 sections, then I might tell her to do a reduction for one of the baby too.
She is 26 years old. She is para 1. And
Yes.
she's diagnosed MCMA at 12-week scan. She has one live issue, and this is her second pregnancy where she's got MCMA twins. So what would you suggest for her?
MCMA has a lot of chances of having complications. So you can counsel her, one, that you can continue both of them, but we'll need to monitor it more frequently, maybe every 2 weeks. There is a chance of TTTS, there's chance of selective FGR, all those things what we've already spoken. But we could also tell her that she already has one child and maybe MCMA has high risk, and if she is interested in not having a twin and all this monitoring, there is an option of an MTP also, because MCMA has a high risk of cord entanglement also and preterm deliveries. And third is an option of reducing one of the fetuses, which again has its own risk. So you'll have to put all of them in front of her for her to decide. Here, because you specially put P1, one baby is alive, and it is not an infertility, and she's just 26 years old, maybe an option of terminating the MCMA twins is also there. Vatsala, you
Gynecologist wants to differ.
Vatsala,
So I was just trying to say monochorionic, monoamniotic, you will be electively sort of iatrogenic prematurity will be there. You will be delivering them around 32 to 34 weeks plus intensive monitoring from 28 weeks onwards. Many times we put them in the hospital to do their NSTs morning, evening to pick up any distress. So there is a lot of intensive monitoring required, but then again, we have to give the options to the couple and they will make a choice. If they want to continue, we will monitor and carry on like sort of the pregnancy and manage accordingly.
So what are the challenges? This woman has gone into labor. She said she wants to carry, and now she has carried to 26 weeks. And now she has gone into preterm labor. So what are the challenges in management in such a twin pregnancy? Dr. Neeru, ma'am, would you like to say something?
Yeah, continuous CTG is very, very important. There may be beat to beat variability, or there may be cord accident, cord prolapse.
She is 26 weeks and she's gone into labor. Do you want to try, to stop that pain? You want to give etoposide or something?
Yeah, definitely.
Atosiban. You want to give atosiban, or you want to try something?
If she's a low risk, like Doppler is normal, growth is normal, then I would definitely like to stop the preterm labor pains. I would like to give them steroids and like to give them atosiban or anything tocolytics we have to give them.
Now she doesn't have pain, but what she has is a, incompetent os-like feature, and it's 26 weeks. Membranes are bulging. What do you want to do now?
I'll take the culture, urine culture, HBS, give antibiotics accordingly, bed rest, strict bed rest, tocolytics, atosiban, also 37, initial dose of 7.5 milligram, then 37.5 for 24 hours.
Do you want to give her a stitch or not?
26 weeks, I don't want to give the stitch. Before 24 weeks, yes, I would like to give maximum up to 25 weeks. After 26 weeks, there may be even again going into the labor chances. So I don't want to give stitch at this time. Then if I give, then I definitely counsel the patient that she may even go in labor. She may have rupture of the membrane at that time also.
Okay. Dr. Garima, you want to add something?
Progesterone also, so that my tocolytic work properly.
Yes. Dr. Garima, you want to add something before I go to the expert?
Emergency Searchlite can be tried as a desperate option. After taking consent regarding her going into labor and having ruptured membranes.
Vatsla, ma'am, you want to add something?
Other thing is we have to see, like, depending on your nursery, if she goes into active labor, if the babies are salvageable according to your nursery, you may want to give Maxwell if the pediatrician says so, and then do a cesarean if you want to save the babies, if it is monochorionic, monoamniotic twins. But if the prognosis is not good because the nursery cannot save these babies depending on the gestational age and weight, then you may have to counsel accordingly and let her deliver vaginally.
But still, I want to prolong for 2 days at least so that my steroid cover can be given properly.
Yes, but 26 weeks again is a gray area. Some nurseries are good, they may be able to save the baby. In that case, then it's better to do a cesarean section for a monochorionic, monoamniotic twin. But if the prognosis is not good, then maybe there is not a good nursery facility, we can allow her to then deliver vaginally if she goes into active labor.
Vandana, ma'am, would you like to differ or you agree?
So you started off saying that there are no contractions at all. So you're talking about over distension and an incompetent cervix with no contraction. So there is a chance of doing a rescue cerclage at this moment also, but depends on the NICU. If my NICU is able to save a 26-weeker, then I will just give that 48 hours for steroid and Maxel to work, and then do a cesarean section, because for MCMA it is better to do a cesarean section if we want to salvage the babies. If my NICU is not that great and I have a long length of cervix, but it is opened up, I might do a rescue by putting in a Foley's and try doing a circlage and then give tocolysis. But before that, I have to counsel the parents that this may leak anytime, the contractions may start, and when it starts, we will that time do a section for her. But 26 weeks is salvageable baby. So it is better than you transfer to an NICU where the facilities are better for 26 weeks salvageability.
One thing, my question to all gynecologists, do you want to transfer in utero or you want to transfer the babies?
In utero, definitely.
Yes.
Yeah, and our IVF twins, many times patient go in labor at 26 weeks, 27 weeks. And by giving good antibiotics, tocolytic and culture, we have prolonged 2 weeks, 3 weeks, many times without giving stitch also in these. So that they at least reach by 30 weeks and we have a good, even though we have a good nurseries at Gurgaon, but still we want like 1 day in the uterus will save 3 days outside, definitely.
That is one take-home point for our gynecologists. So, cervix at the mid-trimester anomaly scan is 15 millimeters. It's an MCDA twin pregnancy. So, what is the importance of cervical length assessment in such a case? Is it important to measure the cervix, and why?
It is very much important to measure the cervical length because we have to decide upon the placement of cerclage if needed. So we have to assess the cervical length, ma'am.
Okay. So if you see that the cervix is, there is cervical insufficiency, then will your management differ? It's a monochorionic pregnancy. Will your management differ? Would you like to give a cerclage?
Cerclage may prevent the preterm delivery in case of even not in monochorionic, irrespective of this thing. We can go for a cerclage. It may prevent preterm birth and perinatal loss. And
especially in a case of monochorionic twins, what are the complications with cervical cerclage placement? You've placed that cerclage. What are the complications that can happen in such cases?
There might be infections, and cervical damage can happen on all. Even the placement of cerclage can provoke PPROM and preterm labor and pregnancy loss. So it is there is we have to manage accordingly. If it is absolutely important, then we can go for a cerclage.
Yeah, but we take the cutoff limit 20 mm. If it's less than 20 mm, we would like to put cerclage. Before giving cerclage, we definitely take the cultures. If the cultures are negative, urine culture, HVS, everything, then we give the culture, give the toculotis also, and strict bed rest for at least 48 hours or so after the putting stitch also. And give counseling of membrane rupture and going in labor definitely in all the cases.
So now my question is for the experts. You people are doing a lot of cervical length measurements. In twins, does the length of the cervix exactly correlate with preterm labor?
Vatsala, you want to take it?
So just like in singleton, cervical length measurement just predict preterm birth in twins also. But again, like there's not much data to say there's a short cervical length, whether you should be putting a cerclage or you should be giving progesterones. But if there is no previous history of preterm birth in a twin with a short cervix, you can give prophylactically progesterone, vaginal progesterone. And if the cervical length is less than 15 mm, you may offer her cerclage. It may be beneficial.
Vandana ma'am, you want to add to that?
So
means a 15 mm cervix, does it mean preterm labor in twins?
So for singleton, we have a lot of studies to define which size is corresponding, and if it is more than 2.5, you don't need to put in a stitch. But for twin pregnancy without a history, there are not too many studies which have been done. But yes, a cervical length of 1.5 centimeter in a twins, because here I expect later on more interventions might be required. They could be poly. I would also put a cerclage at the normally time that you have defined it at. So I would put it not 2, even 2.5. And as what Dr. Neeru said, we'll do a swab, see for infections. If there's no infection, we would put a cerclage at this 15 millimeter, and they do well.
Now we go to the next question, that this is a G2P0 MCDA twin pregnancy and there is size discordance. So what are the implications of growth discordance on perinatal outcomes? Dr. Garima, you're still there? Dr. Garima?
Yeah, ma'am, I'm here. Growth discordance, it usually has a very poor, it's associated with poor perinatal outcomes. And basically, there's increase in early neonatal complications like respiratory distress, sepsis, necrotizing enterocolitis, scissors, etc. And also, if it's very early onset, then there can be chances of intrauterine fetal demises, and that can have a deleterious effect over the surviving twin also.
Okay, Neeru ma'am, this is for you. You know, we have discussed so much about the placenta today, but what are the other etiologies that may cause growth discordance? Just because it is an MC twin, we are thinking it's the placenta, but could there be any other etiologies?
Dr. Asha, can I just...
Maybe torch infections.
Yes, ma'am. Yes, Dr. Vatsla.
Can you please excuse me? I actually had some other commitment. Can I leave?
Thank you. Thank you so much.
Thank you so much. Had very interesting.
Thank you for all the time you've given.
Thank you.
Yes, Dr. Neeru.
Along with the placenta abnormality, there can be other risk factor like torch infection, or there may be any chromosomal anomaly, or there may be smoking. Other causes also, any infections, that also we have to rule out when there is growth discordance.
Anybody else wants to add something to that?
Smoking.
Discordant anomalies mostly, because infections and all will affect both the fetuses.
Yeah.
Placental sharing is the major cause.
Major.
Then with the vascular anastomosis, which can be the second cause. But other things, as we have for any other IUGR, infection, any genetic disorder also, that could be, although it is monochorionic, may affect one fetus and not affect the other. Any structural abnormalities, like if there is a gastroschisis, they are associated with FGR. If there's a single umbilical artery, if any cardiac abnormality. So any anomalies in one fetus can also be there as a cause for the discordancy. So all these FGRs, they start off from your NT scan. So your CRL discordancy, the NT discordancy will predict, basically the CRL discordancy will predict whether they will develop IUGR later on. And they will need to be monitored by Dopplers later on, and the discordancies.
Now you've talked about abnormality, and now you have one fetus is showing omphalocele at 20 weeks. It's MCDA twins. What do you want to do with this patient? Does your counseling differ? One baby has omphalocele, and we know that the outcome is going to be bad for that baby.
So is it to me?
Anyone who's present? Otherwise, you're there to actually take the message across for everyone. Neeru ma'am?
If there is omphalocele in one twin, first of all, we should remove our mindset that in monochorionic, one twin is having abnormality, we have to deliver the second baby. No, now we have fetal medicine specialists with us, so we have to have a good follow-up for them. but we should definitely tell them after 4 weeks we have to get.
And this is omphalocele.
Omphalocele, okay, yes.
So omphalocele, and it is a MCDA twin. What are you going to do with this patient? Vandana ma'am?
So
Back
it
to
is
you.
MCDA means that they probably will have the same genetic makeup and one has a structural anomaly. So first we will need to do an amniocentesis for one or both the fetuses. So I will want to do for both the fetuses because there's a discordancy in the structure of the babies. So it is possible that one of them could be genetically abnormal, the omphalocele one, and the other one normal. So I'll do amniocentesis for both the babies to see whether it is genetic or not genetic. So first is that. Second is omphalocele is surgically correctable disorder. So if I don't find a genetic abnormality, I can actually tell them that omphalocele can be operated later on and can do well. Unless I see a huge omphalocele and the parents are not interested in a baby for surgical outcomes. But omphalocele, if it is not genetic, is a surgically correctable disorder, and we can follow both the babies once we've done a microarray for both the babies and both of them are normal. We still need to tell them that they can be associated with omphalocele constriction of the bowel, dilatation of the bowel loops, gangrene can happen, polyhydramnios can be there, and we might need preterm delivery. She will require a tertiary care center and an ICU. The other option is if the parents say that or a genetic disorder comes in one of them, or the parents say we don't want this, then we can do a reduction for one of this baby, which can be done with a bipolar or by RFA. So that is how I will do for these
Now,
cases.
my question to all the gynecologists who are present here, when you have diagnosed an abnormality in a fetus and it's a monochorionic pregnancy, do you think the parents need any kind of counseling, a professional counseling?
We have to definitely rule out chromosomal anomaly. Microarray is must.
That's not what I'm saying, ma'am. All that medical part is done. Do you think they need psychological counseling?
Definitely.
Psychological, financial, they have to meet a pediatric surgeon. They need to understand the cost involved as well as how to take care of that child after birth and the chances of preterm delivery, the
See,
money.
she's 20 weeks. Today, we can do an MTP up to 24 weeks. So there is one end of the spectrum where a simple talipus, they want to do an abortion.
Yeah.
And then there is multiple heart disease also, and they don't want to do an abortion. So.
And here there are two babies involved.
Yes. So what would you suggest? You want them to go to a psychologist for assessment or what? Or you think what you say to them is enough?
We have to see the patient's socioeconomic status. We have to see the married life. If she's a IVF, 35 weeks, conceived after so long, then we'll definitely like to carry out. Or she's 26 years, just now married. She cannot afford so much surgeries, multidiscipline approach, daily ultrasound, everything, then she could have go for MTP also. So we have to take the shared decision.
So now we are nearing the end, ma'am. This is a basic question that there's a lady, Gravida 3 Para 2, but only one living. Okay. Now she has come, BMI is 38, monochorionic monoamniotic twin pregnancy, 38 BMI. Okay. So do you want to send her for an MRI for confirmation, or you're happy with the ultrasound?
MRI for what?
She's come for MTAS, no ma'am, mid-trimester anomaly scan.
No, our ultrasound is the best modality to diagnose any disorders. So you could actually do a transvaginal also for things which are, if it is cephalic, one fetus, you can see the brain. And you try to get to areas of the abdomen where the fat is less. So our ultrasound is still the best modality. MRI is only complementary to ultrasound when we see a disorder and we want to see that disorder and confirm it.
So basically, MRI cannot be a replacement for ultrasound. It is only confirmatory. Just because it is MCMA and the patient is obese, we are not referring for MRI. Is
Yes.
that the point you want to make?
Yes, definitely.
All obstetricians in this group, do you agree to this?
Definitely.
One more.
But in case of conjoined twin,
yes.
Comment on MCMA. A lot of diagnoses come as MCMA and they are actually MCDA if the membrane is not well seen. So if you don't see, it is very rare to have an MCMA. So try looking for that membrane by the either transabdominal or transvaginal, because MCMA is only 1%. So
Vandana ma'am, she is your patient. You've done her NT scan, okay?
Yes.
And you've said it's MCMA.
On lot of them come with a without saying it MCMA, and we call it as MCDA. So I'm saying look at the membranes more. Yeah.
Okay.
Only that.
Ma'am, so this is a 32-year IT professional couple, very Google savvy. Now they have MCMA diagnosed, 8 weeks. They are very Google competent, reading a lot, very anxious. So they are going to ask you a lot of questions. So what do you think is the psychological impact on such patients, and what support services should we offer?
Obstetricians, please.
Yeah, obstetricians, please. Dr. Garima? Dr. Gopalpriya is, Dr. Gopalpriya, ma'am, you're there?
Yes, ma'am. Ma'am, definitely for such patients, the counseling part is very important because as we all know that MCMA twins, for that matter, any monochorionic twins have a lot of complications. So we need to give them the medical information regarding the possible complications and the need for frequent checkups. And when the complication arises, how we are going to manage. And we should give them at each stage what would be the decision making point and the cost financial constraints that they may be put under with respect to testing, like if it is going to be any interventional testing, like how much it would cost, and also regarding the risk for a preterm delivery and the cost implicated with that. And it should be a shared decision between the parents, then the gynecologist, and the obstetrician, and also the fetal medicine unit. So it would be a joint decision, and but beforehand we must give them all the information. And with respect to counseling, definitely we can give them the support groups. There are many support groups available, so that they can discuss with the other parents who have put under similar situations, and so that they will get the parent point of view more than the obstetrician point of view. So definitely psychological counseling is very important for such parents.
One thing that you people, everybody has to remember that they are IT professionals. They are very, very Google savvy. So in that case, do you think all our counseling has also to have a signature on it?
Definitely, ma'am. We need to take the informed consent for whatever point of counseling has been done. And it is very important for documentation, because at some point of time, we may suggest them to continue the pregnancy. And if at all they deliver a baby at around, say, 26, 27 weeks, and they are having to go through a lot of financial strains as well as emotional. If you had told us that such babies will suffer lifelong morbidities and disabilities, we would have taken a alternative decision. So we need to take a written consent for whatever joint decision that we take with the parents.
Thank you so much. That was an extremely important point, that whatever counseling you're doing, because especially in monochorionic twins, we cannot guarantee anything. We are going to check everything, go on checking over and over, but there are no guarantees. And we also need to be medico-legally safe. So that brings us to the end of our session. Before we really end it, I would really like everyone who are present here, would you please give a take-home message? Neeru ma'am, first from you.
Counseling is very, very important. Financial, we have to tell them all the possible complication of monochorionic, like TTTS, TAPS, growth risk, everything we have to tell in detail for the patients. and definitely multidisciplinary approach. Frequent ultrasound, shared decision, have to involve pediatrician, have to involve fetal medicine specialist, and time-to-time management.
Thank you. Thank you. Dr. Garima?
And the first line I heard in this lecture, no, there is no entity like twins. It's always a monochorionic twin or a dichorionic twin. That is the take-home message for me. So this assessment has to be done properly, always.
Always. So do you do your own scans?
No, ma'am, it's the radiologist who's doing
So then what are you going to demand from your radiologist? You know, we have to fill that form now, what you want from the radiologist. So what are you going to write in that?
So ultrasound, especially for the assessment of chorionicity, if it's a twin pregnancy expected, especially for chorionicity, that should be mentioned.
And amnionicity.
And amnionicity, yes.
Thank you. Thank you so much. Dr. Gokul Priya?
Yes, ma'am, 2 points which I learned is, one is that in monochorionic monoamniotic twins, stage 1, there is no stage 1 as it's going to be a single sac. So we may not find the poly oligo sequence here. So we have to directly look into the fetal bladder to stage the TTTS for the monochorionic monoamniotic twins. So we have to go from stage 2. And the other one is TTTS versus TAPS. There will be no oligopoly in TAPS. So very good points to be taken home.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you.
So Jaishree, would you like to add something before I go to our expert who's still with us?
No, ma'am, for me, the same thing which Dr. Garima mentioned, twins is always either dichorionic or monochorionic. And I think Vandana ma'am mentioned another point that usually you do not have MCMA, usually they're MCDA. So be very particular, check for the membrane before you come to any conclusion.
Okay. Okay. So Vandana ma'am, the last point from you.
So starting off, one is the chorionicity is extremely important, and that has to be done in the first trimester itself. So your NT scan in twins has to be very well done, because you can predict from there TTTS also, FGR also, preeclampsia also, and preterm also. So your NT scan in twins is extremely important to do. Then we are doing surveillance, but you don't call them as TTTS only. You could have TTTS with FGR, you could have TTTS with TAPS, you could have FGR with TAPS. So it is not TTTS, then it is only TTTS. So a TTTS will not have a growth discordancy. So if there's a growth discordancy, then it is TTTS with SFGR. So if there is a discordancy, then it is TTTS with FGR. You will manage it as an FGR plus a TTTS. And always MCA peak systolic velocity has to be looked at. If you don't look at it, you will miss out on all the TAPs. So TAPs has to be seen, because if you keep doing umbilical and ductus and uterine, you will miss out on the TAPs, and velocity is important in that. So umbilical ductus is important in TTTS. In TAPS, it is the middle velocity which is important. And for TRAP, so anyway, you will know there is a TRAP. And for all TRAP, it is reduction to be done. So monitoring is important. Discordancy, if it is 40%, then the gestation decides. If your gestation is 28-30 weeks, then probably you'll deliver them. If it is 22 weeks, you will do a laser or RFA. So the management is not very well defined. It needs to be looked at a lot of more things than just whether it is TTTS or it is TAPS. So TTTS also you could do an RFA, or you could do a placental ablation. If there's not much discordancy, ablation is better. If there's a severe discordancy in the growth in TTTS, then RFA may be better. And the costing according to that also, what the patient can really afford.
Thank you so much.
I think.
Thank you so much for this.
Thank you so much, Dr. Asha ma'am. Thanks for making us part, and we all gynecologists gain a lot from you all in this panel.
Das, sir, would you like to say something? Boliye, Vanna ji boliye.
Just I was saying that you are doing a great work by teaching everyone about all these complicated things also.
Yeah.
So starting from smaller things and now going on to complicated things, you have this Searchlight is a good. I have all my fellows who have logged in also to listen to Vivek Krishnan as well as Prathima Radhakrishnan and your panel itself. So you are doing a good educational work for everyone.
Thank you so much. It's because of you people who actually join in and make the take-home points relevant that the program goes well. So thank you so much. Vandana ma'am is
Last but
going
not the
for
least.
perinatology committee.
Yes.
So
please, can I ask you all to please vote for me for perinatology?
nominate her first.
Nominate ma'am for her.
First nominate in May.
Yes.
And me for food drug committee.
Yeah, that's what we're going to. Last but not the least, please nominate Dr. Asha.
So thank you. Thank you so much for being with us. Thank you all delegates. Thank you Corona Remedies for being our academic partner. We meet next week with primary dysmenorrhea, something that everybody deals with and nobody actually knows how to deal with. So we'll be dealing with primary dysmenorrhea next week. See you again. And then week after that will again be obstetrics. So see you again. Goodbye. Good night. Namaskar.
Thank you.